Hello and welcome to the International Skin Tear Advisory Panel's second Global World Without Skin Tear event. My name is Samantha Holloway and I'm the president of ISTAP. Whether you're joining us live or watching a recording of the webinar on catch-up, you join over 1,500 people who have registered for the event. We're delighted to bring you a truly international programme with speakers from around the globe. I would like to thank them all for supporting ISTAP's vision of a world without skin tears and for bringing their expertise to raise awareness. I would also like to thank ISTAP's Board of Directors for devising the webinar programme and for providing local support in their respective countries. Equally, the event would not have been possible without the support of the Nurses Specialised in Wound Ostomy Continence Canada, for which we're a sister society. And finally, I'd like to also thank and acknowledge the support of our corporate partners, Monlica and Essity, for supporting the event. Why is the World Without Skin Tears Day important? The answer is because data on the prevalence of skin tears shows that there is a problem. A summary of prevalence data from Van Tichelen et al. 2022 highlights the frequency of skin tears in long-term care, acute care, community and palliative care, with figures ranging from 4.7% to 26% in long-term care, rising to 41.2% for individuals with dementia. In acute care, excluding paediatrics, the rate is 6.2 to 19.5%. Regarding where the data comes from, we can see that the majority of prevalence studies are undertaken in Australia, with fewer studies in other areas of the world and less in areas of Europe. One of my recommendations would be for more prevalence studies to be undertaken. Data is powerful and could help to illustrate more accurately the occurrence of skin tears to inform prevention strategies for what is largely a preventable injury. How can we achieve a world without skin tears? There are many ways, but fundamentally we need to promote evidence-based practice. That evidence is out there. We also need to practice person-centered care, placing the individual in the centre, involving them in shared decision-making and supporting self-care where appropriate. And also working as a team is vital. And today we are one global team. So how can you help in ISTAP's mission of a world without skin tears? You can be an advocate for evidence-based practice by implementing recommendations from our best practice documents. We've developed 3 consensus documents to date, including the Prevention and Management of Skin Tears in Aged Skin, Holistic Strategies to Promote and Maintain Skin Integrity, and Prevention and Management of Peri-Wound Skin Complications. They're all free to download from our website. You just need to become a member to access them, and membership is free. Please be part of the wider conversation and help us spread the message that it's not just a skin tear. You can follow us on Twitter using the hashtag WWSTD2023. Please don't forget to tag us in @SkinTears. Let's get skin tears trending today. Our educational programme brings together colleagues from our international partner community, as well as global experts in the field of skin integrity. Our intention was to create a truly global event which addresses topics such as skin tears in vulnerable populations, importance of moisturization as a preventative strategy for skin tears, the challenges developing countries are facing in managing skin tears, also the risk of infection and how this can be prevented. We will look at risk skin and how this links to skin tears, and also examine the evidence base for dressing selection. And finally, we'll look at a bundle approach and how this can be applied potentially to skin tears. There will be an opportunity for questions at the end of this presentation, and certificates of attendance will be issued after the event. A recording of all the presentations will also be available via our website within 5 days. So thank you again for joining us. I'd now like to invite our first speakers to join us. Dr. Ray Samuriwo and Winthrop Professor Fiona Wood. Thank you, Ray and Fiona.
Thank you very much, Sam, for that introduction, and thank you very much for everyone in the audience for joining us. I'm really very grateful for you, all of you joining us, and for making the second annual ISTAP, A World Without Skin Tear Day, successful. So it's my pleasure and privilege to introduce our first speaker, Professor Fiona Wood, who is one of Australia's most innovative and respected surgeons and researchers. She's a highly skilled plastic and reconstructive surgeon and a world-leading burns specialist who has pioneered research and technology development in burns medicine. So without further ado, Fiona, you're very welcome, and thank you very much for taking time to participate. If you wanted to start off by telling us a little bit about yourself and your story and how you've come to work with vulnerable populations.
Well, thank you very much. I feel very much like a bit of an interloper this evening because we know the focus of skin tears is in the age population, but I'd like to sort of share some of my lessons in the burns population, which of course is predominantly in the children, young adults, and increasingly in the elderly. And so that's that skin integrity and the vulnerability of that skin and how we really drive and strive to retain that integrity in the early healed skin can teach us a lot, I think, about how we can prevent skin tears as well. So I'm a plastic and reconstructive surgeon. I work here in Western Australia, and I've spent most of my life in trying to understand and grow skin and really drive this whole regenerative agenda. And in that context, the skin integrity, skin failure fascinate me, and I think part of this whole paradigm is addressing such issues as skin failure. And I know my colleague will follow, Keryln Carville, who did some work that's always intrigued me, looking at moisturizing skin to reduce and prevent skin tears. And I think both the neurology and the moisturizing is something that we need to investigate a bit further. But if you'd like, I will share some of my thoughts with you. Should I share my screen? Right.
Yeah, that's fantastic. So if you want to proceed and share with us some of your lovely lessons learned, thank you.
Thank you very much. Ooh, where are we? Thank you very much indeed. My sincere apologies for that. The random button clicking got me there in the end. So sorry, everyone. Here we go. Managing skin tears in the vulnerable population. So first of all, I think, let's spare a thought of what is skin. And it's a multifunctional dynamic organ that does do so much. And this that dynamism, the restoration of that skin surface and over time, I think is really important for us to think about. Thinking about the function and what we're trying to restore gives us insight into how we can treat our patients. And certainly from my perspective, in a burns context, every intervention from the point of injury will influence the scar wound for life. And so those interventions across those continuum has to bring together, in my view, the three things, the triangle of care. What does our patient need? And this is across the board. It doesn't matter what the pathology with respect to understanding the assessment of the patient is the fundamental key. And then we bring together the resources available to optimize the outcome. Where are we operating? Are we in an intensive care or a nursing station? And anything in between, on the roadside or in the operating theatre? What are the resources that we've got available? What is in our cupboards? What are our dressing? We have to know our environment of operation, and we have to facilitate that environment of operation to escalate it and ensure that we have the best available that we can in that space, and our skill, our knowledge and our experience. So we bring this together, our patients' needs, our knowledge and experience, and our environment of operation, then that will give us the outcome. And that's worth going back to every triage point, every sort of clinic point, because things are not static, particularly in skin, and our patients are not static. So we have to really address and address those needs at every single point in time. I am going to take red that everyone on the call has an understanding of the whole processes of wound healing, because that's what we're trying to optimize. We understand that there's changes in that wound bed that can be optimized locally and systemically. And so understanding the pathophysiology of wound healing and our opportunities really guides our therapy going forward. And for a burn injury, as I've said, occurs in the vulnerable populations all too frequently. Our therapies are guided by how deep the injury is and how big the injury is over the surface. So we lose skin integrity, and we have to restore that with our primary dressing systems, our acute care, and then we get our primary integrity. So what do we know? We take a step back and we know that, delayed healing increases scar risk. We know that infection delays healing. We know edema increases the risk of infection, and inflammation increases edema, but the response to injury is inflammation. So what can we do about this? We have to understand that inflammation is good, but needs to be controlled. Edema is an opportunity for him. We can treat edema, and we shouldn't forget it. We can treat infection. And so all these things provide us opportunities for therapeutic intervention, whether they be anti-inflammatory strategies, our edema management, our infection control, all around tissue salvage. Because what we want to do in a skin tear or in a patient who has the primary healing from the burn and then becomes vulnerable, as I'll discuss in a few moments, what we have to do is focus on that rapid restoration of the epithelial layer and then the protection of that epithelial layer whilst there is a tissue integration. So with our skin tears, we know the problem is vulnerable skin, classically in the elderly, but I'll contest that in a few moments. We know that that skin is vulnerable to mechanical stress and strain. Often it may be a dressing removal. And so understanding that the primary wound healing, the primary epithelialization, which achieves restoration of that epithelial layer, is only one step in the whole process. That epithelial layer then has to be bedded in. We have to be integrated. We need the development of the dermal epidermal junction. We need the development of the keratin layer. We need the restoration of the skin microbiome. So this process goes way beyond that initial restoration of the epithelial layer. And in order to ensure that the patient is not vulnerable to rewounding, then we have to understand protection over a prolonged period of time. And I think protections involve very important in prevention, absolutely. In our elderly population, we know that if we prevent the skin tear in the first place by strategies which are well articulated in the policy documents you see that have been discussed already by Sam, we know prevention is better than cure. But even when you've been through this whole cycle of breakdown, restoration of epithelial integrity, integration of that skin tissue, control of the edema, ensuring that there's no secondary breakdowns from infection, then prevention again becomes really important, because you've established absolutely this patient is vulnerable. So you should never forget the inflammation, the prevention. Time to healing is a driver for us in burn injury. We know that the time to healing is fundamental in the scar outcome. And it's fundamental in ensuring that the healed surface, the skin surface, is less liable to be vulnerable to secondary trauma and breakdown. The epithelial integrity, I think, is a fascinating area which we do a lot of research on. And we know that in scarring, we have disruption of the epithelial barrier at the cellular level. For example, the intracellular adhesion molecules within a keloid scar are poorly expressed. And does this allow ongoing inflammation? Because you've got the barrier to the surface, the skin microbiome is disrupted at that cellular level. So you've got ongoing disruption and drives to inflammation. So understanding this pathophysiology, I think, is, again, as I've said, an opportunity for further investigation and further research, because once we've established the skin integrity, how do we keep it? And how do we sort of as a card carrying plastic surgeon, how do we turn the clock back? How do we facilitate skin integrity that is more youthful? Because intrinsically, that skin integrity that is more youthful, for want of a better term, is better innovated and is more likely to actually be more robust and therefore less liable to skin to tearing. So this is the skin grafts that you can see. Traditionally, we put a skin graft on in our burn wound, and you can see that that's pretty vulnerable for a prolonged period of time whilst it becomes mature and established. We have to take donor sites. They're vulnerable too. This is a hypertrophic scar in a donor site that really is worse than the recipient site. And so we have to consider those issues and ensure that the dressings in the sites we have rendered vulnerable by harvesting skin are protected in such a way that this does not happen. We spend a lot of time, that's beyond the remit of this talk, trying to drive regenerative repair with cell-based therapies, ensuring that restoration of epithelial integrity. And this is really an interesting space to think about it, particularly in our elderly, with where the wounds are large and the stress to healing using conservative therapies is probably a step too far. Then we can harvest small areas of skin and cover much bigger areas from a smaller donor site with cell-based therapies. So that's a thought for therapeutic intervention in skin tears in the extreme cases. So this is the surgical intervention that we're undertaking, removing that necrotic tissue. And I'd show this because to really demonstrate the vulnerability, we're accelerating this person's time frame because their skin is much more vulnerable at an earlier age because of the stress of that healing. Our patients are vulnerable also because of their extremes of age. This is a child that's been treated conservatively, but the small area on the arm is a secondary tear through little fingers getting underneath the dressings. And certainly the dressings, as adhesive dressings being removed, cause skin tears. They cause skin tears in babies too. So we have to pay meticulous attention to detail in our dressing changes, in our protection of these early healed wounds. Some people are vulnerable due to the extent of injury and the stress of healing. And you can see some areas here that have had secondary skin loss through to the dressing, basically disruption of the dressings and required secondary healing. We've got vulnerable due to compromising nutrition. One of the things I think is really important for us all to think about these days is obesity and how that compromises wound healing. And we've really got to understand in the patients who have profound weight loss, and understand their chronic malnutrition and trying to facilitate healing with the background of obesity followed by bariatric intervention, and then the electrolyte and nutritional disruption of that is certainly something that is emerging as a significant clinical pathophysiology that compromises wound healing and compromises that restoration of skin integrity. And so the vulnerability due to trying to move with vulnerable scars You can see that these extensive scars, people trying to move against them, shear, mechanical forces disrupt that skin surface. Vulnerable with our interventions in themselves. We want to measure earlier. We want to improve scar by getting our pressure garments on early, but that in of itself has to be the consideration of our secondary interventions with the pressure garments have to be very thoughtful in terms of fabric and design and fitting. Where do we put the zips? Making sure there's no extra pressure, making sure there's no shear when things are going on. Again, this is important in the elderly. Are you using protective stockings subsequent to a healed skin tear? And how are you going to get that on? And what fabric is going to be most appropriate for that individual? So we spend a lot of time trying to understand the fabric design, and we have fabrics that wick from the surface, and then we have layered pressure garments so that we have shearing between the layers of the garments, for example, in the early phases, so that we don't drive these mechanical forces on the surface of the skin, which leads to the disruption. Again, vulnerable to the contact media. We want to drive this scar in a positive way, and we're using these things that can in of themselves cause disruption of the skin. So this drivers to skin post-burn injury, I think I've whistled through this, but when I stood back from this, I thought, this is the space I live in, and I don't live in the space exclusively in elderly people. I support the burn service and run the burn service in the children and adults, as you've seen. But the drivers to vulnerability, my apologies, I've realized I've split this, and my age should be at the top, but the extremes of age for different reasons. Comorbidities really drive poor skin health, for want of a better term. Poor nutrition drives poor skin health. Infection, the delay in restoration of the skin microbiome, the technique of repair and the developing dermal epidermal junction, how people are vulnerable to blistering. So there's a lot of things that we've learned in our burns patients that are relevant, I think, to looking at the systemic issues that we can influence, whether the patient has a skin tear in a nursing home, has a disruption of their newly healed burn in an elderly situation, or in a situation where we're trying to drive to return to work. And so we have to optimize, stand back from this and across the board, optimize systemically, particularly optimize comorbidities, diabetes, nutrition, all those things. Hygiene, I cannot emphasize hygiene too much. The whole body hygiene is so important, because we need to ensure that we restore skin integrity and retain it. When we come to the dressings and the local dressings, I'm going to leave to the experts to talk about this, because we can certainly have a chat as we ask for Q&A. But I think you've got to look at a dressing that provides moist wound healing, protection of the surface, facilitates edema control, again, something I cannot emphasize too much, and facilitates function. One of the things that I think is really important is function and restoring sensory and motor integrity within the skin construct. The skin is a big neural receptor. It needs to be touched. It needs to be massaged. It needs to be used. So us in really driving our protective dressings, we have to also be aware that we need to retain hygiene. We really need to ensure we've got edema control, but we also need restoration of neural integrity. And because people survive massive injuries like this and live with them throughout their life, and we teach our patients how to protect their newly healed skin, their developing scars, and also their skin for life, because it is vulnerable. And we know that hygiene, edema control, massage, and function are all tie up to making sure that we retain skin integrity for life. Thank you very much indeed.
Thank you very much, Fiona. A very engaging talk and very interesting. I was just making notes all the way through about all the different types of vulnerable populations that you mentioned, and certainly there are a few more than I'd initially considered. I think I identified 8 distinct groups. So you talked about children, bariatric patients, people who've had profound weight loss, also people who have scar formation, which causes vulnerability, the need for care and attention around the use of pressure garments, but also being mindful of contact media in the form of dressings as well, and also the older person. So thank you very much. And in light of all that you've said, I just wondered if there were a few key points that you wanted to share with the audience in terms of key lessons that you've learned. And particularly, I'm aware that a lot of people in our audience will be coming from developing countries or transitional countries in the global south, or will be working in settings where the resource provision is limited. So any sort of top tips from your own practice that you might want to share with colleagues working in settings where resources are limited?
I think I can't, straight off the bat is hygiene. And soap and water, simple. You know, soap and water goes a long way. And the next thing in skin, in retaining skin integrity is moisture, and ensuring that simple moisturizing is, it doesn't have to be fancy, but again, it maintains that skin health. And I'll let Keryln speak about that. But the thing is that I think sometimes we forget is edema control. And the other thing I think we sometimes forget is nutrition. And you know, and it's not that easy on occasions. It's not easy sometimes to ensure that that the best nutrition is given, but it has to be discussed and considered and not forgotten. It may not be possible to have, you know, a high protein drinks and the likes that we use, but there's lots of other alternatives. And then when you get to dressings, again, I think it's really interesting because there are so many things that we could use, but I think we've got to look at the individual, look what's in the cupboard, look what we're used to using, and do the very best we can by bringing those 3 things together, like I said at the beginning. What does your patient need? What have you got available? And what is it that you can do with that? And that's what you can deliver. And if you need more, then you lobby, you push, and we all shove around and keep asking our politicians or whoever. But when you've got that patient in front of you, you do your very best with what you've got. And so I think that, and we should all respect that. And I think that's really important too.
You know, I think that's a really important point. I just had one other question, I guess, in terms of a lesson that we could all learn. So at the very end of your talk, you highlighted the importance of protecting skin for life. And I wondered, from all your years of experience, if you had any advice on key messages to give people who've experienced burns or skin tears and the public at large, just about the fundamental things that they need to do in terms of protecting their skin for life.
Massage. And you don't have to go to a total body masseur, do it yourself. Yeah. Skin needs to be touched. Retention of neural integrity means you need to use it or you lose it, sort of thing. That's what we say about our movement. You use it or lose it. And sensation is the same. If you don't touch, it's very dynamic. I can tell you, so you've got me on something I'm really excited about now. If you're burnt here, your nerve density will change here and your neural patterning will change. Now, I think that is fascinating. We're spending a lot of time at the moment. We're using transcranial magnetic stimulation to drive neural plasticity to try and improve burn outcome. Now, that is a left field for this discussion, but it's born of our understanding that we need to develop both motor and sensory, and we need to retain that stimulation So you need touch. People need touch. Go swimming because the water feels different. Yeah. Massage your skin. Use it. And yeah, if you ignore your skin below your knees and don't touch it, then yeah, that neural integrity is dynamic and it will change.
Lovely. Just one final question. So in your response to my first question, you talked about the importance of being a student, engaging our politicians and funders. So it's a more personal question, because one of the things we hope for in ISTAP is to develop people as well. So what's your advice for people who are looking to make a difference at a local level? How can they survive? How can they be resilient in what are often challenging situations if people may not understand the importance of looking after the skin?
I think it's always good to get a champion, and it's always important if somebody comes through, somebody of influence comes through your clinic. That really does help. Or someone of influence's parent, a mother, father comes through your clinic. That is helpful in getting this message across. But I'm a great person for asking. One thing is absolutely sure: if you do not ask, you won't get. Yeah, that's absolutely for sure. So you've got to thicken your skin. Funny, sorry about the pun, because I've been told no far more than I've been told yes. But that doesn't stop my asking. Even though I'm way over 60, I will still keep asking. Still keep advocating for my patients, asking for, applying for grants for research or whatever it may be. So for all the youngsters, it's not, don't take it personal when you get knocked back and people say no, but don't stop asking. Just ask differently. Work
Lovely.
out how to ask. Yeah.
Lovely. That's fantastic. So thank you very much, Fiona. So many messages for us to take. So at this point, I'll hand back over to Sam. Thank you very much, Fiona. Thank you.
Thank you very much, Ray. Thank you, Sam.
Thank you to Ray and Fiona. Fiona, before you disappear, I know you have to go. There's one question that's come in that maybe I can ask you, and it's from Trish Idenson. Hello, Trish. It's about, what do you suggest clinicians can do to promote restoration of the skin microbiome?
I think this is a really interesting area that we're researching at the moment. We're just putting together a grant to try and understand what is a normal skin microbiome and how it changes over life. So it's a really interesting question. We know that the skin, there's a lot of discussion around how the changes can influence the healing, but there's no really established norms, for want of a better. So how do we know we've got back to normal? And so that's what we're trying to put together at the moment in our environment, because I think everybody's environment is different. We can't say, well, we'll try and normalize the skin microbiome as is if we've got based on African data or UK data. Yeah, so we have to have local data. And I think one of the things that we do know is excessive use of topical antimicrobials will disrupt the microbiome and will cause a disruption of skin integrity as well. So we know that. And so part of restoring the skin microbiome is being very judicious in your use of topical antimicrobials. We're moving further and further away from things like, bathing people in chlorhexidine and stuff like this, because we know that this is an important part of the total holistic healing. But I'd hope maybe when we come to this day in a couple of years' time, I'll be able to say, I've got the answer to that question. Because if we have to know what the normal is for that individual. 2, we have to know how it's different in the healed site. And 3, we have to work out how to drive normalization. So I think we're really early in this journey at this point with our knowledge.
Thank you, Fiona. And I'm sure Kim and Karen will pick up about the infection side of things in their talk. But thank you again, Fiona, for joining us. It's been an absolute pleasure. And there's been some lovely comments coming through on the chat about how passionate you are and they want more of you. So yes, you mentioned a couple of years' time, we'll book you in for that. Thank you, Fiona.
To see you all.
Thank you
very much indeed.
Thank you. Bye-bye. So thanks to Fiona and Ray. We move on to the next session, which is Dr. Keryln Carville. And Keryln will be talking about evidence behind moisturization for preventing skin tears. So thank you.
Good morning to everybody. My name is Keryln Carville and I come from Perth, Western Australia. And I thank the organisers for the privilege of being able to participate in this really important event. Let us hope we can indeed stop skin tears. The title of my presentation, as you will see, is Evidence Behind Moisturisation for Preventing Skin Tears. Skin tear epidemiology data is varied across the world, whether that setting be aged care residents, hospitals or community settings. In Australia, the reports in residential aged care facilities are anything between 41 to 59% prevalence of skin tears within that population. In hospitals in Western Australia, again, back in 2007, 8, 9, 11, we conducted statewide surveys across all 86 hospitals in Western Australia, which is the largest state in Australia, and we found prevalence between 8 and 11%. And more recently, community care in Western Australia, we can report 15 to 17% of skin tears, primarily amongst our aged care residents. We know that skin tears are the most common wound amongst elderly Australians across all health settings as a result of this data. And it is estimated that a third of aged care residents with a mean age of about 87 at any given time have a skin tear. 17% of known wounds in the community setting, again in Western Australia, are found to be skin tears amongst people of all ages, but predominantly those above 55, 60 years of age. In summary, mostly it's appreciated that skin tears are generally underreported in Australian settings. But skin, as we know, is part of the integument, and it is our largest body organ. I think it's certainly the organ we take most for granted until it's injured, or possibly you've got a hot date and want to do something with it. But the outside appearance of the epidermis, that is the part you look at every time you look in a mirror or look at your skin, has a prime function to play, and that is the stratum corneum, the outer layer of the epidermis, has a role in skin barrier function. Skin barrier function is also referred to as epidermal permeability barrier or the lipid barrier. And the skin barrier function is responsible for maintaining skin hydration and supports the skin's antimicrobial defense barrier. It also prevents the underlying structures from desiccation. The skin barrier function primarily involves the stratum corneum, and this amazing layer is comprised of approximately 25 layers of flattened corneocytes. And corneocytes are the name that we give to the cells that are derived from keratinocytes in the underlying 3 or 4 layers that comprise the epidermis in that anatomical location. Within the stratum corneum, we have what's known as a natural moisturizing factor, and it's found within the corneocytes. And the natural moisturizing factor is a humectant, and the humectant causes it to attract and store water in the stratum corneum. And this helps primarily to keep the skin hydrated and smooth. Now, if we look under a microscope and look at this amazing layer, the stratum corneum, it's been related to really a bricks and mortar presentation. I think this was a really clever analogy because the corneocytes, the cells, are interlinked with corneodesimomes, and they are what give, if you like, the cells support and help to control the transepidermal water loss. So instead of this bricks and mortar function serves the purpose then that it controls transepidermal water loss more readily than if the cells were just stacked upon each other with a clear, uninterrupted passage to the external corporeal environment. Surrounding the corneocytes, we find lamellar lipids, and they are comprised of ceramides, cholesterols, and free fatty acids. And they have a role to play, again, in keeping the skin hydrated and smooth. Very important. But as we know, as we age, the skin takes on a very different appearance. We get thinning and flattening of the epidermis. We have decreased epidermal proliferation. The cells in the outer layer lose their elastin. We have atrophy and contraction of the dermis, decreased vascularity of the dermis. We have changes to the amount of collagen and loss of the collagen that we have. And we have decreased sebaceous gland function. That means we have decreased oil or lipids. And the only good thing I can think about when it comes to aging is that we sweat less because we have reduction in our sweat glands. Overall, we have a vascular response, which is often compromised. We have altered or reduced sensations. And the outcome of all of this is that we have dry and fragile skin, which is very susceptible to injury, such as skin tear. Back in 2006, when we started to prepare to conduct statewide surveys across all 86 public hospitals in Western Australia, and that was followed by reviews of private hospitals and community care as well, we devised the STAR, the Skin Tear Audit Research Tool. And this is the tool that we used when we conducted the surveys in 2007, 8, 9, and 11. What we found was that we found skin tears across all ages, in neonates, right up to very elderly Australians or Western Australians. And as you can see, the number of skin tears increases significantly from 70 years of age onwards. So we know that primarily skin tears are very much a condition of more matured elderly skin. We found that skin tears occurred across all of the medical specialties within our hospitals, but primarily they increased in those units where individuals often required more assistance, more handling, such as palliative care, spinal injured, the medical wards or the rehabilitation wards. Interestingly enough, we found more skin tears occurred on the arms of hospitalized patients, followed by the leg and then other body parts. But in all of the studies we have done across other sectors, particularly aged care, we've found similar findings. We get more on the arm reported, but in the community, we find more skin tears on the lower limb. Largely, one assumes because they are more ambulant individuals than those who are in hospitals or residential aged care. So we know that there are a lot of reported risk factors, and those reported in Australia that are related to individuals' characteristics relate very much to impaired mobility or the inability to reposition independently. Those with a falls risk or a history of falls, a history of skin tears, older adults is generally reported as the major or a major risk factor. Those with malnutrition, hematoma, and dementia. And largely due to the research of Dr. Robin Rayner, we have found that skin characteristics reported very much not only relate to purpura or ecchymosis and solar elastosis, but overall the general appearance of fragile skin. So prior to, it would have been about 2008, we decided that we would start to investigate risk factors in a hospital population. We chose a hospital that had 500 beds, and we conducted a case control study on the population that was 50 years or older. So our sample size was 150 cases and double that number, that is 302 controls. And we investigated everything. We looked at those in the next bed. The controls formed those patients who were in the bed closest to the case, who had not had or never had a skin tear. We looked at their age, their gender, their comorbid conditions, their medications, their reason for being in hospital, how ambulant they were. We looked at everything. We looked at their clothing. We looked at how much handling they had. And the risk factors that we found when we did log regression analysis identified senile purpura was a significant factor, ecchymosis, hematoma, the evidence of previously healed skin tear, scarring, edema, and importantly, the inability to reposition independently. So handling had a role to play. Around 2010, we were fortunate to participate in a cooperative research centre, which was an Australian government initiative, where we came together with universities and other research groups and conducted research. And this was a really good opportunity that we could expand the research, particularly in looking at risk factors and interventions that we thought possibly may or may not reduce the risk of skin tearing. And aligned with that was particularly an interest in looking at moisturizing the skin. It was a perceived common consensus that skin that was elderly needed to be moisturized, but we had no evidence to say how often, with what, and did it actually make a difference. So one of the studies we conducted looked at defining what was usual care in residential aged care facilities. And then we set out to look at diagnostic risk assessment related to aging skin, the use of moisturiser and the use of moisturising cleansers, and what it would cost the Australian government should they be provided. Dr. Robert Rayner's PhD looked very much at the component of diagnostic risk assessment, and she set out to investigate associations between skin tears in the elderly and the skin's transepidermal water loss, its thickness, elasticity, sebum production and perfusion. We used a population of 200 residents that were in residential aged care, and it was a prospective descriptive study with informed consent. And the baseline measures were recorded and repeated at 6 months, and skin tear incidence was then followed up. We looked at their age, their ethnicity, their medical history, mobility and activity levels, medication, skin characteristics, using the Fitzpatrick skin assessment tool. And we looked at non-invasive technologies for determining transepidermal water loss, dermal elasticity and thickness, and sebum production, and of course perfusion. So in looking at some of these tools, we used the Dermalab combo, and that evaluated skin thickness, elasticity, hydration, transepidermal water loss, colour in the form of melanin and erythema. We looked at sebum production, and we could find no sebum on the lower extremities, for that matter, really the upper extremities of elderly patients or residents. And we looked at their tissue perfusion, and we conducted skin blotting, looking at transepidermal skin proteins in partnership with the University of Tokyo and the team there. What we found as a result of that study was that the clinical predictors for skin tear risk in that elderly population were the presence of purpura and the presence of elastosis, which is primarily sun damage. The skin becomes rougher, tougher, and really demarcated. And we also found that collagen 4 was missing in this population, and collagen 4 helps to stabilize the basement membrane. So as a result of her research, Robin came up with this definition of skin tears, and I think specifically for the population she studied, it was very applicable, that they're superficial or full thickness, trauma-induced injuries that primarily occur on the extremities of older persons with clinical elastosis and or purpura, and are associated with age-related changes to the skin's structural and mechanical support properties. That last component is really important. Age-related changes to the skin's structural and mechanical support properties. So that then also influenced the study we conducted to look at how could we optimize elderly skin and whether or not moisturizing topically made a difference or not. So we conducted a cluster randomized control study across 14 aged care facilities that at the time had what we term high care and low care residents, and they were matched equally. So 7 high and low care facilities were matched with another 7. We had 899 beds, and in total, because of the turnover of residents, we had 968 residents in the study. Those that were randomized to the control group had usual care. That could be ad hoc application of a non-standardized moisturizing product. Those that were randomized to the intervention group received twice daily moisturizing with a pH neutral, perfume-free, commercially available moisturizing cream. We matched them for age and gender, and as is the case for residential aged care facilities in Australia and that population, we tend to have more females, as you can see, as compared to males. The mean age was 86 years, the median age was 87. there was a range between 40 to 104 years of age. We had some in the 40s that were there primarily because of disability, and there was nowhere else for them to be housed. We looked at the locations, and we found, as was the case in our hospital studies, that we found more skin tears on the upper arm and the lower arm of residents as compared to the leg and then other body parts. Interestingly, we found when we looked at where the skin tear occurred within the facility, the majority of them, 68%, occurred in the resident's bedroom, and their bedroom and their shower or bathroom is usually co-joined. So technically it's getting in and out of the bed, and of course activities involved in personal care. Interestingly enough, we found that most of the skin tears occurred at peak handling times. That is, the times residents would be got out of bed for personal care or breakfast, and again when they were put back into bed for rest periods or evening, night-time sleep. And of interest, we also found that more skin tears occurred in the middle of the week on a Wednesday and a Sunday, and try as we may, we have not been able to find out the reasons behind that. Some interesting ideas have been proposed, but as yet they haven't been validated. But what we did find was that when we moisturized the skin, that is the arms and the legs, the extremities of the 968 residents across those 14 facilities, we reduced skin tears by virtually 50% in the intervention group. So, you know, we had 450 skin tears in the intervention group as compared to 978, and that is a reduction of close to 50%, which was a significant finding that twice daily moisturizing of the arms and the legs could do this. So at that given point, we were asked, well, what would it cost if this procedure it was conducted across all aged care facilities in Australia? And so we set about to conduct a moisturising impact study. We went back and we prospectively modelled the application of moisturiser, and we looked at the time taken to apply it and to report and to document any skin tears that occurred, and importantly to treat them. And then we looked at that based on 20%, 40% and 60% of aged care residents that were in facilities at that time in Australia. What we found that the mean cost to report a skin tear injury was about $4.97 that is Australian. To dress the wound cost about $37, and time to report was about 12 minutes. So that cost was based on 12 minutes time. The time to complete the wound care, the mean time to complete wound care was 20 minutes and 12 seconds. And the dressings and solutions used on a mean cost of about $18, $19 based on $31.46 per hour for nursing time at that level at that time. So then we were asked, well, what does it cost to pay for moisturiser, and what would be the outcome? And so at that time, 6 months of moisturiser that would allow moisturiser to be applied twice daily to the arms and the legs was very minimum. It was $17.19 Australian. The time to apply, and it took 1 minute, 8 seconds to apply moisturiser to 2 arms and 2 legs of each individual on average, and that was $150. So a total of $167 to purchase the moisturiser and apply it. We then compared that to what was ad hoc care at that time, and obviously there was basically the cost of moisturiser, interestingly enough, because there were more people with skin tears in that control group, 480 as compared to 428 in the intervention site. It cost more for moisturiser, and it cost less time because there was only daily application versus twice daily in the intervention group. And so we also cost that at twice weekly, which when we looked at standard care, some organisations had a very broad approach to only applying moisturiser twice a week. And of course, no care is the cheapest care. The cost to treat the skin tears over 6 months, and again, I just like to highlight that in the intervention group that got twice daily moisturiser, there were 428 skin tears at a total cost of 27,500 Australian dollars, or a mean cost for the treatment of $64, as compared to the 488 residents in the control group who ended up with skin tears, at least one skin tear. The cost was significantly more to treat at $57,190 and a mean cost of $117. So that calculation was based on 452 skin tears in the intervention sites and 940 skin tears in the control sites. Sorry, I should point out they were residents with skin tears, not skin tears in that calculation. The cost of moisturiser in treating skin tears, we were asked to do this work, and what we found, the number of residents, 428 in the intervention site, the total cost of their care was $99,083 and a mean cost of $231.50. And the control cost, that is, if they were done daily, so versus twice a day, was $250 ultimate cost, mean cost to the resident. So even twice daily moisturising and treating less skin tears demonstrates cost savings as compared to daily moisturiser and the need to treat more skin tears. So when we did the calculations based on 20%, 40% and 60% of residents that were at that time residing in aged care facilities, we had 106,369 residents in Australian aged care facilities. The total cost, as you can see, for twice daily moisturising, that's including the cost of the moisturiser, the time taken to apply, and the cost to treat the skin tears that occurred when we worked out that equation, was $49.5 million, as compared to daily moisturiser and the treatment was $49,914. So the cost difference, that is daily minus twice daily, really the result there was 404,202 days. And I remember thinking at that time, is that all we saved? Is that all we saved when we moisturised twice a day, 60% of residents in Australian nursing homes? And ironically, my mother, who was the same age at that time, 87, as the mean age in our cohort, developed her first skin tear. And let me tell you that that really upended her quality of life. One skin tear meant she had to have a bandage on or a dressing on her leg. It caused her great inconvenience. She couldn't put her high heels on. She couldn't go dancing 3 times a week. And it just brought it back to me that really it is more than the cost. How do we benchmark the cost of well-being and better outcomes for those we're privileged to care for? So after that, we thought, well, we have to cleanse these patients, these residents. And normally in Australia, most residents might be showered daily or second daily, subject to their preference. And we thought, well, what if we used a moisturising cleanser rather than plus or minus a topical moisturiser? Could we eliminate some of the time spent in topically moisturising, or would it be beneficial rather to continue that? So we set out to conduct a study to determine if the use of a pH-neutral, perfume-free skin moisturising cleanser during routine bathing of aged care residents reduced the incidence and severity of skin tears as compared to the reduction in incidence and severity achieved with the use of twice daily moisturising lotion when applied topically, and to determine if that same moisturising solution during routine bathing reduced the incidence and severity amongst aged care residents who received no standardised skin tear moisturising protocol. So at that time, we conducted a cluster randomised controlled trial across 2 large residential aged care organisations who both had 14 aged care facilities, making 28 aged care facilities in total. We had 649 residents who agreed to and consented to participate, and there were 239 in the intervention and 410 in the control group. Those that had participated in the nursing home that previously had twice daily moisturiser applied, that was now standard practice. So they were allocated to either the intervention arm or the control arm, that is those that agreed to participate. And so those in the cleanser and moisturizing group intervention had an intensive moisturizing solution cleanser that contained 60% moisturizer. And they were bathed in that moisturizing solution and had topical moisturizer applied as well. In the control group, they had their usual cleansing with whatever their cleansing moisturizing lotion was or soap, but had topical moisturizer applied to their extremities. In the other nursing home that had no standard control for moisturizing application, they were randomized to intervention or control, and they had the intensive 60% moisturizing cleanser plus ad hoc topical moisturizer, if it was their preference. And the control group had their usual ad hoc moisturizing lotion or soap plus ad hoc moisturizer. Now, what we found, interestingly enough, and we analyzed several times, was that we actually had more skin tears in the group that had the moisturizing cleanser, which, just to remind you, was 60% moisturizer, and the moisturizing lotion cream applied to their extremities. And this then highlights for us the fact that there is what is termed a coefficient of friction of skin, where skin can get to become too moist, as we know with other conditions like intertriginous dermatitis or incontinence-associated dermatitis. So more research needs to be done into what amount of moisturizing cleanser and, again, topical moisturizer. So at the moment, the best evidence is topical moisturizer applied because it is longer lasting, and whatever cleansing solution that is deemed applicable for that individual. And maybe just to bring this together, the question that we've long been asked is, well, does it matter what moisturizer you use in the form of either a cleanser or a cream or lotion, or for that matter, an ointment? And I'd just like to remind us all that moisturizer is the umbrella term, and within it you have various ingredients. And in fact, there are many ingredients in most of the moisturizers we use, and you only have to read the bottle of a label to identify how many components there are. But primarily they could be divided into three groups. You can have humectants. They are basically hygroscopic substances. They promote water retention in the skin. Examples would be propiongglycol or butylene glycol, glycerin, urea, alpha hydroxy acid such as lactic acid or glycolic acid, and salicylic acid. You'll also find emollients. Emollients provide an oily film on the skin, which softens skin and traps moisture, prevents transepidermal water loss. And it also protects the skin against irritants that could be found by exposure to effluent or other fluids. So in effect, these tend to be emollients, being an oil base, primarily liquid paraffins or liquid oils. We also find occludants in moisturizers, and occludants work because they form a film barrier. This protects against water vapor loss. So it could be things such as paraffin, petrolatum, lanolin, and the polyacrylate barrier films. So moisturizers are products used to add moisture and to protect the skin. Some contain preservatives and some do not. And of course, preservatives could be irritant to the skin. So when we're selecting moisturizers, whether they be in the form of cleansers, lotions, creams, ointments, or barrier films, we need to consider what is their component and what is their function. So cleansers we use, of course, to lift dirt, and they will contain surfactants. They are basically either a soap or a synthetic detergent or a combination. Some cleansers, as we know, contain various amounts of moisturizer, which tend to leave a film on the skin. Broadly speaking, if we have lotions, lotions are comprised mostly of 20% oil and 80% water. They're very easy to apply, but they're not long lasting. And most of these products contain a preservative. Creams comprise roughly 50% oil and 50% water. They have a longer lasting effect. They take a little bit more effort to get on than a lotion, and many contain preservatives. Ointments, on the other hand, are comprised of 80% oil and 20% water. They take a lot more effort to apply and to rub into the skin. And they contain things such as beeswax, paraffin, and they usually don't contain preservatives. The barrier films, which usually are polyacrylate films, contain silicon polymers such as dimethicone, and these generally form a dry, water-repellent, transparent barrier to the skin. So if we're thinking about cleansers and what cleanser we should be using, then we need to know that cleansers all contain surfactants, as do soap. And surfactants aim to reduce surface tension on a liquid. And surfactants are broadly grouped into anionic, that is negatively charged surfactants, and these products lather, and they cause a good lather and they rinse off. And a good example of that would be sodium lauryl sulfate. However, sodium lauryl sulfate can be very drying, especially to oily skin. Cationic or positively charged surfactants, they reduce the surface tension of the liquid, but they don't lather. Their lather effect is very, very limited, if at all. And these can be quite irritant on skin, particularly skin of the very young and the very elderly. And cationic surfactants are usually found in household cleaners, such as window cleaners or surface cleansers, where you don't want a lot of lather. Amphoteric surfactants are both negatively and positively charged. These tend to be low irritants on the skin. They reduce the irritant action of anionic surfactants, and often they have antibacterial properties and resistance to hard water. So these are the surfactants we tend to find in skin cleansers and shampoos. Non-ionic surfactants, on the other hand, have no electric charge, which makes them resistant to water hardness. So these non-ionic surfactants we often find in laundry and dishwashing detergents. I'd just like to mention soap, because a lot of people tend to still want to use soap. And we need to be mindful that soap is derived in its basic ingredients, usually from animal fat or vegetable oil. It tends to have 100% pure lye, and lye is a metal hydroxide. It's traditionally obtained by leaching wood ashes or a strong alkali, which is highly soluble in water, and this can produce caustic basic solutions. And of course, we know that the skin is pH slightly acidic in its pH, and so to optimize good skin health, we should be really looking at something that is not alkaline, but either slightly acidic pH or neutral in its formulation. So other additions that might be added to soap, particularly if there's colorants or fragrances, which often require an alcohol substance to set, can be particularly drying to skin. So in total, and finally, what I'd like to say is that really from the age of 25 onwards, we start to produce less sebum. And so we should be moisturizing on a regular basis. And obviously in high risk skin, such as the elderly skin, we need to think about applying moisturizer twice a day, gentle application of pH neutral, non-perfumed moisturizer. And, you know, this is something that we've been able to demonstrate does reduce the risk of skin tears. So thank you very much for your time and the opportunity, and I wish you all well. And these are my references. Thank you very much.
Thank you very much, Keryln. And I'd like to invite you back in at this point, if that's okay, because I believe you're not able to stay later in the day till the Q&A, which is quite late for you in Australia. So there were a few questions came in, Keryln, but I think you answered some of them as we went along, particularly one about pH of the skin and soap there. But Keryln, there was a question that came in about, does skin tone or skin color have an influence on risk for skin tears? And I wondered what your thoughts were on that.
Samantha, that's a study we would love to conduct internationally. And it's interesting because in darkly pigmented populations, such as those we might find in Africa or parts of Asia, there are few skin tears reported. And I know Kim and I have talked about this as well, and it is a study that really does need to be conducted. We find skin tears mostly in Caucasians, followed by Asians, but the darkly pigmented races just seem to have, whatever the skin characteristics are, less or more tolerant to skin trauma in the form of skin tears. But, you know, we can't make that statement really without evidence. So it does need to be studied. Good PhD for somebody.
Yes, and we've got plenty of people listening in, so maybe there would be somebody that's interested in that.
I'd love to talk to somebody about this one.
Certainly it does cause us some challenges as an international panel where we're trying to be inclusive and reflective of all different skin tones. So we did put a call out for anybody with images of skin tears in different skin tones, including white, white Caucasian, across the skin tone spectrum, to get in touch with us, because we would like to be more inclusive in our materials and our teaching, our education. So I think it's a particularly important area for us to engage in.
Indeed. And that's been our observation in our darkly pigmented Aboriginal people as well. So, you know, and maybe it is darkly pigmented populations across the world, but there may be other factors that we have to consider. And that would be around, obviously, the microclimate and the impacts of temperature and moisture on skin. So I think there's a lot to it that needs to be studied.
Exactly. So I've got another question here from somebody, Sajida. Thank you, Sajida. What percentage urea concentration would you use to prevent or decrease skin tears?
We didn't actually study urea per se, but we know that urea is quite often used and it forms very much a humectant as well as an emollient on the skin. But I think, to be honest, I don't think it matters really what you use as long as you use it. And if you can find something that's pH neutral and something that is non-perfumed, unless it's got friendlier alcohols rather than those more vicious alcohols that are sometimes used to set perfume, then I think it's a good thing. But it's the application of moisturizer that's important. And across genders, you know, for some reason there's a perception that elderly men don't like to moisturize. Well, I think it's a matter of training. And I've trained my husband well, but he still does get skin tears. So he has to moisturize twice a day or he's in trouble.
Thank you very much, Keryln, for your contribution today.
Thank you. I wish you much success. Thank you.
Thank you and goodbye. Thanks. So we'd like to move on now to a colleague of mine, Dr. Harikrishna Nair from Malaysia. And Harry's going to be talking about skin tear management in developing countries. Thank you.
Very good day to everyone. It's a pleasure to be presenting on skin tear management in developing countries. And it's a great honor to actually be involved with the International Skin Tear Advisory Panel, which have been doing a lot of good work, basically. And today is the Global World Without Skin Tears Day in 2023. I'm Dr. Hari from Malaysia, and I'll be covering the importance of actually looking at skin tears in the region, especially in all developing countries. Now, if you look at this, basically, this is the Asia-Pacific region, the whole of Asia, basically, with Southeast Asia, where we have got the ASEAN Wound Council, which is about 10 countries. And then we have got Central Asia. We've also got basically East Asia and North Asia. And we also have got, under the Commonwealth Wound Care Resource Alliance, which I also chair at the moment, there's also many, many Pacific islands and all that. So all these countries are actually denoted as developing countries or underdeveloped countries for some areas. I come from Kuala Lumpur Hospital in Kuala Lumpur, Malaysia. This is actually part of the hospital. It is actually the ambulatory care center where the wound care unit is set. And this hospital has about 2,500 overbeds and close to 12,000 staff with every specialty in medicine. Now, if you look at the studies in Asia, the problem being basically is in Asia, in the developing world itself, there's not much of studies on the prevalence of skin tears. So this particular study by Yi Cheng and also Keryln Carville and all that, looked at the prevalence of skin tears in acute care setting in Singapore, right? Now, Singapore is more of like a developed country, but it's one of the countries with a study looking at this about close to 7 years ago. Now, it's an extensive problem. And the thing is, even though there is now more focus and all that, you find that there is no report of skin tear epidemiology before this. So they're actually looking at a methodology to look at the types of skin tears, determine the prevalence, and current nursing management of skin tears. So in this particular study, they did a point prevalence study, all right? And you find that there was about 144, 98% of patients consented to skin inspections, and skin tear prevalence about 6.2%. And you'll be surprised that most of it were in the range of 70 to 89 years old, so in the geriatric age group. So therefore, basically, the thing is, there was lacking in the knowledge of skin tests, there was lack in documentation, and even if it's available, it's not consistent. So therefore, we need to have a proper skin tear classification tool, standardized protocols, and a comprehensive educational program. And that's why the ISTAP is doing a lot of good work, basically looking at consensus documents, looking at best practice, publications, and also looking at education. I always say education, education, education. As my role as president-elect for the World Union of Wound Societies, and also chair of the Commonwealth Wound Care Resource Alliance and the ASEAN Wound Council, I always talk about education. That's important. That's why today's session, looking at global, what do you call this, a world without wound care, a world without skin tears, is actually a very, very important session, because you got a lot of different consultants and specialists talking about skin tears. Now, in this prevalence study, they started at about 7:30 a.m. sharp. They introduced the patient, they performed skin inspections, and whether there's any skin tears or not. And then they looked at what they call is documentation. What are the findings in the data collection tool, and also looking at anatomical location, the sites, all right? And in this case, they use a star category, all right? So then they complete a survey and proceed to the next patient. Now, were there any wound dressings? So you assess the types of dressings, all right? So this is important because to assess any documentation on skin tears within 24 hours, all right? And any current documentation on the last 48 hours. That means, did they not only assess and document and manage, and following which basically follow up the patient? So that's important. Now, if you look at temporal classification, you've got acute wounds, you've got chronic wounds. It's following basically time itself. So skin tears are acute wounds. They're frequently misdiagnosed and underreported. Most people, when they look at this kind of wounds, especially in the geriatric age group, when they have a skin tear, when they have a, let's say, because of trauma, or even because of normal friction, or even what you call this, if there's any tears because of infection or anything, any of these things. So they need to basically, report that. And you have different ways of classifying this. So like look at linear skin tests. So the skin is split, or the skin is splitting in a straight line. And then you have flap skin tear. That is a segment of the skin or skin and underlying tissue that is separated from the underlying structures. All right. So these are what they call as common presentations of these patients whenever they have skin tears. Now, this has already been alluded to by my colleagues, basically, who have talked about the ISTAP skin tear classification. That means whether there's no skin loss, there is a linear of flap tear, all right, which you should reposition to cover the wound bay. Or you have a partial flap loss. Okay, so you cannot reposition it. And then you have a total flap loss, exposing the entire wound bay. Now, you would think that these are very, very small, minute conditions, but these are the conditions that you need to basically look at, you need to identify, you need to assess. Now, if you don't, what happens is it can get infected. It can become a full-blown wound, all right? I know in the developing countries, what we also look at is basically pressure injury, all right? Looking at type 1 pressure injury, looking at type 2 pressure injury, and all these things. But interestingly, this is a very common thing, especially now. It is the geriatric age group is becoming more. the numbers are increasing basically in developing countries, and not only like those in developed countries. All right. So when you have these kind of skin tears and all that, you need to make sure what you call this, you close it back, cover it back, and then do proper dressing. Make sure it is not infected. All right. Make sure that it follows the lines and all that when you cover up in terms of dressings per se. Now, the skin tear classification. You have got the best practice, you've got it in Japanese, you've got it in other languages, and then also what you call it, holistic strategies to promote and maintain skin integrity. So these are things that are already been, what you call that, out there basically. And these resources you can get in the ISTAP homepage. And this is important basically because the thing is, we don't have it in other languages, like in what do you call this, the Malay language, which covers an archipelago, or even other languages for, like, let's say, India and also other countries. So we need those things. And if you look at skin tears, basically, number one is you must be able to look at the risk of getting a skin tear. That means the patient could have a fall. It could be patients could be having fragile skin. They can have cuts, they can have scrapes, you know. So a lot of risk factors are there. So you must look at the elderly. And then important, basically look at the precaution that you must take, and then look at these people who actually might have, you know, they might have problems such as friction, there can be other hazards, they can be having illnesses, immobility, and then all of this can get infected. So you need to help, you need to support, you need to make sure the diet, nutrition, make sure that awareness is important. All these are important in the developing countries. Now the problem basically, like, let's say we look at Malaysia. You have got about 634 health centers with wound care teams. You've got about 147 hospitals with wound care teams. But how many of them are actually looking at skin tears? Skin tears is now looked at primary care, basically. And sometimes in nursing homes and all that, they're looked after by the nurses in that area or the caregivers itself. So we need caregiver modules to actually teach them, to actually make sure that they know what is a skin tear, what should be done, what patients or which kind of skin is more predisposed to having a skin tear. Now, the problem basically in the developing world, most of this is not assessed. It's more of not of a proactive kind of management. It is more of a reactive management. That means when you have a skin tear and it's infected or whatever, that's when they come and see the nurse or the doctor and all that. So that is something that we have to change. And hopefully what they call it, this will be helpful. Now, if you look at Kuala Lumpur, basically, fairly developed city, basically, and this is the KL Twin Towers. Now, we need to basically, what I put up here is to show that education needs to be exported everywhere. That means we need to educate them on the importance of skin care. Now, skin tear management is very important in the developing countries because most people do not have proper dressings and all that. So we'll go through all this later when we discuss. Now, what are the decision algorithms? You look at the skin tear, assess, and then cleanse. Now, if you look at a condition where different groups have come out with wound hygiene, that means in terms of looking at what we call this wound cleansing. And then you're talking about debridement if it's infected or whatever. Or if it's not infected, the necrotic tissue and all that. And then you look at refashioning and you talk about dressings. Now, in skin tears, you assess and you cleanse. You want to make sure that it doesn't get infected and cleanse whatever debris could be there. But don't forget, when you also do that, also control the bleeding. Hemostasis is important. Western 85 mentions about physiology of wound healing, whereby hemostasis is very important. So you need to control that. So you have got different types of dressing materials. People used to use calcium alginate, sodium alginates. People used to use what you call that aniline packs in some of the developing countries. You also, what you call this, can use a lot of hemoclots, wound clots, chitoclots, chitosan type materials and all that, which can be used to stop the bleeding itself. All right. And then after cleansing, you need to approximate the wound ages. So classify, measure, document. All right. And then the goals of treatment, basically, make sure you treat the cause. How did the patient get it? Did the patient have a fall? The patient have got vertigo? Maybe benign paroxysmal positional vertigo. Is it because of age? All right. They might be having giddiness and all that. Then implement prevention protocols. That means this is basically when, you know, you have to make sure that, you know, patients who are elderly, there's a caregiver, somebody look after them, you know. Like what I have done even for my mom, basically, I've got CCTVs all around the house, 9 CCTVs around the house to monitor her movements and all that. So I know exactly, you know, if she falls or, you know, she chaps her skin wherever, you know, it's very important. Make sure that all these sharp edges, you know, those furnitures with sharp edges are not actually around. Make sure they avoid the trauma, and then protect the peri-wound skin. Now, peri-wound skin basically, and even other parts, can have dryness and all that. So moisturizers, you must have moisturizers. You can have collagen and glycerin, you can have eucerin, you can have basically aloe vera, any of these things. And interestingly, in places such as even Brazil, South America, in other developing countries, they also have a lot of moisturizing creams. In some places, people even just use simple virgin coconut oil. It's a very simple moisturizer, all right? Instead of, like, here we end up using collagen or that, which is a problem because of the cost, all right? Glycerin is one thing. Vaseline has been used many times also. Emulsicants, emulsifying, ointments, and all that are important. And then you have to make sure you manage the exudate, avoid infection, and pain control, because it's painful. The skin peels off, it's painful, all right? And basically, the treatment options are following the local wound conditions, all right? And persons with a skin tear, always take the course where general health, look at the ambulation of the patient, look at the skin, all right? And then you look at local wound care. Now, local wound care, basically, you need to have atraumatic dressings. So these dressings are those with silicone, all that. We have got the Less Pain Academy. We have got everybody talking about atraumatic dressings in the patients who have pain. We talk about pain as a fifth vital sign, pain-free hospitals, pain-free centers, all that. We need to cleanse, control the bleeding, approximate the wound edges, assess and classify, all right? And you find what you call this, that, patient-centric concerns, activity of daily living, looking at pain control. So educate the client and the circle of care. That means your caregiver also. So it's back to what you call it, looking at DIME. So you're looking at debridement, infection, inflammation, moisture imbalance, and the ages itself. So it is very important. And in which cases do you need to give antimicrobials on that? So look back at the wound infection continuum. When you're looking at local infection, spreading infection, systemic infection, that time you need to cover with antibiotics, local antimicrobial dressings and all that. Now, the assessment is important, whether using the TIMES concept, whether using triangular wound assessment, whether using time CDSC, or whether using timers, all right? A simple assessment. And even when you do a skin tear classification, because after you assess, you need to classify, all right? So like even DIMES and all that, like what I've mentioned before, this is very important. This is the A in your management. And basically, when you look at these kinds of wounds, all right, how is the skin, basically? Okay, so you need to actually, number one, assess this. And then finally, what you call this, manage it accordingly. You can see in these cases, basically, these are the patients where they have the skin tears. It's torn, what you call this, in this area, a bit more jagged and all that, and then it rolls up a bit, basically. So you need to cleanse it, dress it up, and then cover up the skin. Don't remove that skin area itself, because sometimes what happens is the wound will get more infected. Okay, and this is a very common thing for most patients. You can see here, basically, patients have hole marks on that. This is quite a common thing. So that means the prevention is not enough. And in this case, when you apply a dressing or whatever, put up to show how to remove the dressing itself. All right, follow the thing. That means basically you start off from that edge and you pull it following the arrow. Now, why? So that because the skin is torn in that way, in this area itself. Okay, so if you pull the other way, you're going to tear the skin off and you're going to cause more trauma. So here, same thing, when you apply, basically the same concept. They put it this way, so you tear out this way, you open up that way. Okay, and it's important. Now, in most of these developing countries, they're using simple dressings. Some people use pure gauze. Steri-strips is the other thing that they can use and all that to keep it intact and all that. But always make sure what you call this, it must be clean. All right, always manage the hygiene and all that. Here you can see steri-strips put in different ways to make sure that the skin is covering that particular area, and then the wound starts to heal better. Okay, so this is actually a very important concept. And even when you cover up, like in this case, when the skin tear is this way, you cover up this way. All right, and then you put a dressing to keep it in place. So good skin care is very important. So like you see, skin flap, you roll it upward to cover the wound. So any dressing should be removed in the same direction, upward, so it doesn't peel off the skin. So that it's very important when you reposition the flap and remove the dressing. So this is something that you must be taught in most places. Most people will put the dressing on underdeveloped countries or even developing countries. Unfortunately, if it's not in a proper center, a proper wound center or whatever, or even in community nursing itself, you find that the dressings are done by the patients, by their caregivers and all that. So this is important to actually make sure that, because 50% of all wound products are actually bought in the pharmacy. So the pharmacies have to be educated also. And then you need to educate the patients also. All right. And in these cases where, you're going to put it on, you can use even the cotton buds and start pushing it in. So you don't use your fingers or anything because, it's very sensitive, very friable skin that you need to actually have some support. Here, after that, basically use a gray bandage to cover. All right. So this is localized management. So in other words, basically, this is important when you look at skin tears in the developing countries. Manage locally, basically, prevent infection. All right. So you start off basically by assessment, and then you stop basically bleeding, and then you, what you call is cleanse. You close the particular wound with a proper dressing, and atraumatic dressing. A silicone dressing is the best, but those are expensive. All right. So early assessment diagnosis is important, which we find that is lacking in developing countries. And then referrals if required. If you need to basically get a proper place, the patient has got a very bad tear, is infected or whatever, you need to go and see. Interventions, basically. Now, these interventions, whether you have to put what you call this silicone dressings or whether you have got adhesive dressings and all that is important, but cost be a problem. And you need a massive team approach. That means basically it's not just the patient, the caregiver, industry support. You need CSR activities, you need education, you need what we call this, the IT specialists to help, and all of us to work together, doctors and nurses and all that to work together, because this is actually a problem in most centers, not only in hospitals, but also in geriatric care centers, aged care, managed care. We've got so many of these things now. All right. It's actually coming up and all that. And you can see in developing countries, it's actually following suit what's happening in the developed countries, whereby we have these things. But there's still a lot of things to do. When I was actually looking at this lecture, one of the headaches that I had is the amount of studies basically on skin tears in the Asia Pacific region, in developing countries is lacking, is limited basically. In terms of prevention, preventive, what do you call that, intervention or that, same thing. Is very, very limited, what do you call that, in developing countries. So you can see basically in these cases where, you have got, what do you call that, the elderly, and then you've also got what you call it, looking at ideal living, where you're supposed to basically look at how you can manage the patient. You must actually suspect that these patients can get skin tears and all that, so what you must do. So even in Malaysia, basically, when you look at the geriatric age group, all right. So here, basically, I'm just showing you, there were in geriatric age groups and also in these centers, they even do hair cutting and all these things. So you must also teach them, basically, not only about cutting your hair and all this stuff. I mean, looking good is one thing, yes, but also looking at skin protection, skin management. That means in terms of basically moisturizing the skin, making sure what they call is even an older age group person who's having a problem with skin turgor, dry skin, should manage all these things, and you must teach all of them about these things, you see. So that's very important. Now, are you asking the right questions? I know what they call is a good friend of mine, Jackie Fletcher, will be talking to you about asking with skin tear, which is really wonderful. And at the same time, what we call this, I think Professor Karen Uze, another good friend, will be talking to you about infection. Now that's important when you look at all this, basically, when you look at this. So you need to assess. So skin assessment care is very important. Patient-centric skin tear prevention is important, whereby, you need to create a safe environment, make sure, they don't get any injury, handle the patients gently, follow bathing guidelines, don't scrub, loofahs and everything else, don't have to scrub the whole skin, assess the nutrition status, and you must make sure there's a nutritionist or dietitian who can help out, dress the patients properly. Basically, this is important, all right? Because what they call it, you need to have an additional protective barrier to blunt trauma and all that, which is a very common thing. These things happen. And I put up here to the Commonwealth Wound Care Resource Alliance, because that's another group that can work with the ISTAP, basically, looking at all the, what do you call this, different areas where you have got islands and all that, and developing countries. The ASEAN Wound Council has got 10 countries here, same thing. You can look at Cambodia, Laos, many other countries where we need support in terms of looking at skin tear. And for the World Union, I put here global paradigm shift, wound management, specialty recognition. So in 2026, what we want is, we want to see what kind of education, prevention is actually going on in skin tear. So we're hoping, basically, with work with ISTAP and the group, that in 2026, we're able to actually show there's a lot of work that has been done in this area coming forth. So we want to actually be the follow ISTAP, work together with ISTAP, and basically have more what do you call it, programs to actually help in terms of skin tear assessment and also management. So very important. I would like to thank the ISTAP committee. I would like to thank Samantha Holloway, who's been what do you call it, instrumental in pushing forward the ISTAP aim, together with Kimberly LeBanc, Karen Uze, and the whole team, and Sharon also. All of you all have done a good job. I would like to thank you for inviting me, and hope we can work together for the betterment of my patients all over, in not only in the African continent, the South American continent, even in the Asia Pacific region, even in the islands and all that, Eastern Europe, and all these countries basically which require a lot of help, especially in terms of education, looking at skin tear. So thank you again, and hope you have a wonderful session today. And most importantly, basically, is education, education, education.
Thank you very much, Harry. I can see you've joined us live. We've just got a few minutes for questions now, because we do have questions at the end of the session as well. But now you've joined us live, and I appreciate that, because it's probably quite late, middle of the night somewhere for you, early hours. There's just one thing I would like to ask you about, Harry, is obviously ISTAP have a lot of resources out there. We've got best practice recommendations, but what do ISTAP need to be doing anything in terms of adapting the guidelines for developing countries? Or do you think that the guidelines we have suit the purposes for developing countries? Or is there anything in particular we need to think about maybe adapting?
I think one of the things is basically looking at adopting it and adapting it to that particular region. Because the thing is, if you look at the Pacific Islands, especially Fiji, Solomon Islands, and all these things, they don't have any proper protocols on what do you call it, skin tear assessments and everything else. So that becomes a bit of a problem. And then in the Asia Pacific region also, basically, a lot of it's actually doctor-centric in the sense that usually physicians are the ones actually managing these cases. And in most times what happens is basically it's at the homes, and the caregivers are doing it. So we might have to need to basically make it more simpler. And one of the things I was mentioning is having proper caregiver modules, because now at the moment it's all for healthcare professionals. But the thing is, when you have a simple skin tear basically at home and all that, what happens is the family looks after the patients, the caregivers looks after. So you don't actually have a senior registered nurse or anyone who's actually managing it, unless after Karen talks about infection, basically after that, they end up coming to the proper practitioners and all that. So we might need to simplify things, put in what they call this, the basic assessments and preventions, and also what they call this, the basic protocols, and adapt it over. Then basically it'll be easier. So that'll be good actually to get regional groups basically to come in, and they can actually translate to different, what do you call that, languages, and make it like a made easy kind of paper. There is a simple, straightforward, simplified thing that even at homes they can do. Because I think that is one of the things that people have. Because when it happens at homes and all that, when you have got chaps and cuts and all these things, it's like, oh, it's a normal thing. You're like cycling and then you fall down and have a cut. That's all. So people just end up putting what they call this, anything which they get from the pharmacy or even from home, and they say it's done. So you see, that is something which can be added on. Otherwise, most of the ISTAP best practice documents are very good. So we might need to, what do you call that, make it more basic for places where even the lay folk can actually use it.
Thanks, Harry. Yeah, and I think within our recommendations, we do have some simple guidelines that could be extracted out of them. You also make a good point about translation. So that would be something perhaps we could work together on as an international partner activity moving forwards. That would be good to do. But thank you again, Harry. We do need to move on to the next session. So thank you for your time today. And there have been a number of questions that have come up that we will come back to, as I mentioned in the question and answer session at the end, including things like the use of steri strips, which I just want to clarify, but we'll come back to that. But thank you. So I'd like to now move on to our next session, which is Dr. Carynousi and Dr. Kimberly LeBlanc, who will be looking at preventing infection in skin tears. So thank you, Karen and Kim.
Hi, and welcome to our session. My name is Kimberly LeBlanc, and I am the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm also the current Treasurer of the International Skin Tear Advisory Panel, and I'm pleased to have with me today Professor Carynousi. Karen?
Thanks, Kim. I'm Carynousi. I'm Professor of Skin Integrity from the University of Huddersfield in the UK. I'm also Chair of the International Wound Infection Institute. I'm President-elect for the International Skin Tears Advisory Panel, ISTAP, and I'm delighted to be presenting with Kimberly today. Thanks, Kim.
So today what we briefly want to talk about is to really look at skin tears and how infection impacts skin tears. So first, the first thing is, what is a skin tear? Often we're told, well, it's just a skin tear, or people minimize these wounds. But in fact, a skin tear is a traumatic wound, and we defined it as that of a wound being caused by mechanical forces that includes the removal of adhesives, and that severity may vary by depth. But it's important to know it doesn't extend to the subcutaneous layer. And this is one way that we can differentiate a skin tear from other traumatic wounds. So skin tears are very common. And, if you work in the elderly population, we'll certainly hear staff talk about the fact that skin tears are very common. But the problem is that they are greatly underestimated, and people minimize them. They don't think of them as being complex wounds. So we see them predominantly among the aging population, but it is important to know that they can occur anywhere across the spectrum of the lifespan. So from the very old to the very young, or particularly people who have chronic or critical disease. So we see aging skin being drier. We know that as we age, our skin becomes thinner or more fragile. And this is due to the decreases in sebum and sweat gland function. We have that decrease in collagen and vascularity, decrease in the inflammatory and immune response, and the skin becomes much more susceptible to shearing and friction. So we know that prevention is better than a cure, and certainly we really try to we try to make sure we're promoting prevention, because some of the studies have shown us that you're 80 times more likely to develop a skin tear if you have a history of a previous skin tear. And while we've yet to be able to validate a prediction tool for skin tears, the one thing that everybody can agree upon is that if you've had a previous skin tear, you're at high risk for developing future skin tears. So it's really important that we look at individuals' skin and that we ask the questions to people in terms of, what is your skin health history? Have you had skin tears before? And I don't know about you, Karen, but in my practice, very frequently, people just aren't asking that question. They're not asking the question, what is your skin health? And I think if we just started with that, we could prevent a lot of different wounds. But we also look at different ways that we look at the modifiable variables. So we look at the skin, mobility, and general health, and look to see what things can we do to promote skin health and to avoid skin tearing. So I'm not going to read all of these to you, but you can certainly go on to the International Skin Tear Advisory Panel's website, skintears.org, and you can read these in our documents. But some of the most important things we know is moisturizing of the skin. And Dr. Keryln Carville and her team in Australia did a wonderful study where they looked at skin moisturization, and what they found was that you could actually decrease the incidence of skin tears by roughly 50% simply by moisturizing the skin twice a day. So between moisturizing and protecting from trauma and having positive attitudes from our healthcare staff, we do see that we can have a reduction in skin tears. So the assessment part is the key. And this is exactly what I was just talking about in terms of these modifiable factors. So if you look in the middle here, you can see that we need to look to see how we can modify the mechanical skin trauma. How can we change the attitudes of caregivers around the knowledge, attitude, and practices, and what kind of physical environment we can have? So hopefully be able to moderate so that we don't have skin tear development. So when we're looking at risk assessment, essentially what ISTAP maintains is that when we look at the different categories in terms of skin mobility and skin health, if people have any of these risk factors, we should be considering them at risk for skin tear development, and we should be going back to that risk reduction program. And more importantly, if somebody doesn't have these risk factors, we should be reassessing them whenever our patient's condition changes. So if we're looking at infection and risk for skin tears, we know that skin tears are known to cause infection, enhancing the wound size and prolonged hospital stays. Skin tears can be painful and distressing for the patient and their relatives, and their presence impacts negatively on health-related quality of life. And, one of the things, because skin tears are often minimized, what ends up happening is proper dressings aren't applied, proper cleansing isn't utilized. These wounds are often left open to the air or not managed appropriately, and then they quickly become infected. And one of the things to think about is if you have someone with a pre-existing swollen lower leg, so someone has lower leg chronic edema, and they develop a skin tear, well, we now have a complex wound because we have a wound on a swollen lower limb. But frequently what happens is people are not doing lower leg assessments. They're not putting people into compression because it's just a skin tear. So because of that, we have a lot of edema, we have a lot of moisture from these wounds, and they're very prone to infection, and then they become very complex. So wound infection, I'm going to hand this over now in a second to Keryln to really talk about infection from the International Wound Care Infection Institute. I never get that acronym right. And its relationship to skin tears. But we know that all open wounds are contaminated or colonized. So we know that they're all at risk, but they don't all have to become infected. We can prevent it. And these are acute wounds. Skin tears are acute wounds. It should heal in a timely fashion. So 14 to 21 days, the wound should be closed. So if we do the proper treatment and we prevent infection from the get-go, we can actually prevent them from becoming complex. We know that biofilms contribute to delayed wound healing and increase the risk of wound infection. And microbial bioburden is a number of microorganisms in a wound, the pathogenicity of which is influenced by the type that are microorganisms that are present, their growth, and their potential viral mechanisms. So we have to remember that skin tears often occur in our aging population who have multiple comorbidities, so they are at higher risk for infection development. I'm going to hand this over now to Keryln.
And I think it's really interesting what you've pointed out, the fact that a skin tear can become a complex wound. And it's also everybody's business. And I particularly like the point about how we don't always look at lower limb and being able to do that full assessment. So podiatrists definitely have a role here because they're obviously looking after the lower limb. But Kim was very kindly talking about the IWII when her tongue got a little bit mixed up with it, which is the International Wound Infection Institute. And IWII have updated their consensus document in March 2022, to which the wound infection continuum is being updated. And please don't think this can only be used for those hard to heal pressure ulcers or leg ulcers or pressure injuries, but we can also use this for being able to identify and prevent wound infection within skin tears as well. And you can see the continuum here in front of you that shows the different stages of contamination, colonization, and then this bit in the middle, the local wound infection. We once referred to it as critical colonization. IWII didn't find enough research and evidence to actually support that concept, so it's been changed to covert and overt signs of infection. And this is something we should be looking for within skin tears. And this is when you'd be thinking about, has that skin tear become infected? Do I need to be thinking about using antimicrobials? If it's contaminated or colonized, then no, we don't need to use antimicrobials. Absolutely no need for it, no signs of actual infection. But we get to local infection, yes, and of course spreading and systemic infection. And within the continuum as well, you can see how that green darkens as it goes along, and that's showing the increasing microbial burden in the wound. So you can use this when you're assessing your skin tears. And the best thing to do is prevention of wound infection. We're very good at being reactive and saying, oh, this is a skin tear and it's getting worse, or this is a skin tear and it looks really red. But let's start to be proactive and think about how do we prevent it in the first place. And to help you with that, the IWI Continuum also has a management guide as well. Now, these are all free to download, and we'll show you the website later on. But you can also pull this out, so you can pin it up on a wall, or you can put it into your pocket, so you can look at it very easily. And you can see you've got the continuum at the top with the contamination up to systemic infection. Then we talk about look for those clinical indicators of potential biofilm as well. So this is all about a full assessment, being able to identify things at an early stage, and then implement the biofilm-based wound care if you need to. Then you think about therapeutic wound cleansing, and then you think about swabbing. And remember, if you're going to swab a skin tear or any sort of wound, clean the wound first. Don't be tempted to take a wound swab from the dirtiest part of the wound, which is the intuitive thing to do because you think, I want to know what's in there and what's growing. But no, you need to clean everything off, a nice clean wound bed, and then use the Levine technique and not the Z technique. And the Levine technique is explained for you within this document as well. Then you think about your debridement and your post-debridement care, and then you think about the wound dressing. So are you trying to prevent further damage? Are you trying to manage infection? Or are you trying to prevent infection? And at the bottom of this management guide, you can see the step up, step down approach to biofilm-based wound care. So everything's there for you to look at to be able to help you prevent or at least have an early identification of infection within patients who have a skin tear. But Kim sort of alluded to this as well earlier on about the importance of holistic wound management as well. It's not just about looking at the wound and thinking, oh, the patient's got a skin tear, what do I do? It's having the patient at the heart of everything we do, and the carers as well, asking them, how have you got this wound? How did you get the skin tear? Have you got any comorbidities? What medication are you on as well? But also to look at the environment as well. People within acute hospitals, we tend to make sure there's nothing detrimental to the health around the bed environment. But when you go into a patient's own home, they've often got clutter around, they've got things sticking out, they walk into the side of the bed or they walk into the chairs. Have a look at that environment and see whether or not you can help prevent a skin tear. If you can prevent a skin tear, you then prevent wound infection because you don't have a break in the integrity of the skin. However, if you do have an infection, then look at how to reduce the wound microbial burden, optimize response to the person as well. So look at, have they got diabetes? Have they got any other infections? Have they got a pyrexia? What's the psychosocial well-being that needs to be helped as well? If we're not managing the diabetes, then you're never going to prevent that wound infection happening. Remember, we need to be performing wound care in a clean environment. So again, it depends on the environment. Are you in a hospital or you're in the patient's own home? So still it has to be clean when we clean that wound, but also store equipment and supplies appropriately. So if you leave them in the patient's own home, ask them which cupboard you can put it in, rather than leaving it in the middle of the room where the cat or the dog can come and have a smell of it and maybe have a chew of it as well. And also look at your local policies and procedures. So what's there on the formulary for what types of antimicrobials you can use or what types of wound dressings you can use. But importantly, explain to the patient about how to keep that wound clean if they're going to be managing it and what to look for signs of infection. Then they can report back to the healthcare giver at a very early stage. But there's lots of documents out there as well as the IWII. If you look at the Wounds UK website, there's also a really good document on there that's free to download that talks about management and effective identification of wound infection. And you can see here, this is very much based on looking at the wound itself. So what's the wound bed like? What's the levels of exudate like? Always check the peri-wound area as well. And we talk about this a lot, but people sometimes forget to look around the wound area. There's a lot of exudate there. That's going to go onto that peri-wound area, damage the peri-wound area. And again, that's a risk of skin breakdown and then a risk of infection. Use your nose as well. is the malodor there. It is malodor. You can often suspect a wound infection as well. And ask the patient about the pain. Where is the pain? Have they got pain in the wound, or is it anticipatory pain? And by that I mean, is it pain from me coming up to them knowing that I'm going to take the dressing down and do the wound dressing and they think it's going to hurt? If it's anticipatory pain, then the pain isn't anything to do with the wound itself. It's about us having better communication skills as well. And don't forget to document everything you see and do. So be very clear about what did the wound look like when you first saw it, were there any signs of inflammation or infection, what did the patient say about it, was there any odour, was there any pain, and put clear evaluation dates as well when your wound dressing needs changing or for any changes within the patient's condition as well. Don't forget to document about diabetes or any other sorts of medication which may affect the wound, which could then lead to a wound breakdown. But I'm sure you'll all be delighted to know this is the free website that you can go on to and download the IWII document consensus. And then you can pull out the wound infection continuum that we showed to you, and everything you ever wanted to know about early identification of infection and management of infection is within this document. There's also a range of information for you to look at, again free of charge. So if you go to the ISTAP website, you can download all the documents from there free of charge. If you go to Wounds International, Wounds UK, for example, there's a slot on there called TVN TV, and there's people that talk about skin tears, prevalence and risk factors as well. So there's lots and lots of free information for you to be able to understand the complexities of skin tears, but also understand how to identify infection at an early stage, and if a patient's wound does become infected, how to manage it. So thank you very much for listening to Kim and I, and we look forward to any questions you may have. Kim, back to you.
Thanks, Karen, and thanks for that wonderful overview of infection. So now we'll invite you to ask any questions that you might have.
Thanks, Kim and Karen. Actually, for the purposes of time, if it's okay, we will come back to questions and answers in the panel session, which is at the end. But I would like to now move on to the next presentation, which is from our colleagues across the waters, Dr. Ruth Bryant and Dr. Diane Krasner, and they're going to talk about at-risk skin and the link to skin tears. So thank you, Ruth and Diane.
Hi, welcome to the second annual Global A World Without Skin Tears Day. Thank you, ISTAP, for coordinating this event and for the invitation to speak today. I share the podium, the virtual podium today with Dr. Diane Krasner. I am Dr. Ruth Bryant. I'm a nurse scientist at Abbott Northwestern Hospital in Minneapolis, Minnesota. And today I'm going to talk to you about at-risk skin and the link to skin tears. These are my disclosures. Objectives today are to describe at least 5 protective mechanisms provided by the skin, identify factors that increase skin vulnerability or frailty, and place the skin at risk for skin tears. So when I think about the skin, I think about a suit of armor. And that suit of armor provides several methods of protection to UV lights, to toxins, to trauma, pathogens, allergens. It also provides a barrier to infection through the sebum and the acid mantle. It provides sensory perception through pain, so that we can detect pain, vibration, touch, itch, all of those things that we can respond to in that signal harm. And temperature regulation, so that we can regulate heating and cooling, as well as provide a means of communication, so that we have a clue as to the state of the well-being of the individual. So how does it provide all those functions? Well, the skin is has a lot of different structures to it that actually provide those mechanisms for protection. Let's start with the epidermis. The top layer of the skin consists of epithelial cells, and as those epithelial cells migrate to the surface, they lose their nucleus and become keratinocytes. Those keratinocytes then become densely packed and pancaked together to create our intact stratum corneum. And that stratum corneum then essentially acts like saran wrap to lock in lipids and natural moisturizer factors. It prevents water loss. That stratum corneum has a normal skin flora that's unique to each individual, and also has an acid mantle, together providing an antibacterial function. The epidermis then is connected to the dermis, and this dermal layer, as you can see here, is an undulating kind of a layer. That is where that helps protect the epidermis and dermis to not pull apart. They're integrated there, so that as the epidermis experiences some shear, the dermis will move with it. As we age, however, that epidermal-dermal junction will flatten, and tension or stress or shear on the epidermis can result in a pulling apart of the epidermis from the dermis. That phenomenon also occurs in the immature infant with their skin. But otherwise, the dermis below that has all the blood vessels in it, as you can see here, and has the sebum production, the sweat glands, has collagen and elastin fibers, hyaluronic acid, all those kind of activities go on here in the dermis. I mentioned the REAP pegs here. We also have melanin that helps protect us from the sun. So as we talk about skin, it's important to think about terminology that we use. So skin integrity is the condition of the skin being undamaged, not only undamaged, but well maintained. I think that's an important distinction to be aware of. Impaired skin integrity, alternatively, is when skin becomes exposed to external factors and as a result has a decrease in its protective mechanisms. So these two important distinctions are that it's not just a break in skin integrity, it's not just a cut in the skin, it's actually maintaining protective mechanisms. At-risk skin, then, is a state in which the individual skin is in danger of being altered. It's also referred to as vulnerable skin and skin frailty. There are many factors that alter a skin's protective function or challenge the skin. Medications, age, adhesives. You can see the adhesives used on this man's chest. You can see, and if that's changed several times a day, it's going to strip off the stratum corneum and cause damage. The stratum corneum on the baby is much more fragile and easy to strip with the tape that's being used to secure their tubes. You can see this little lady enjoying the water park, and moisture is certainly something that can weaken the tension, the collagen fibers in the skin. We can see aging going on in the skin. We can see in this particular individual the effects of corticosteroids on the skin with the thinning of the skin. We can see the senile purpura developing in this skin, which is puts that person at risk. And other medications, of course, antibiotics alter the skin normal flora, anticoagulants, and as I mentioned, the steroids. I want to highlight age-related physiological skin changes because they're numerous, and if we're aware of them, then we can protect the person. We may not be able to change these, and may not be modifiable, but we can certainly protect them from harm. So thinking specifically about decreased collagen and elastin, so it's not as flexible, it's not as forgiving. Thinning of the epidermis. The dermis and subcutaneous tissue lose their volume. Keratinocyte proliferation is reduced. So as a result, any break in skin integrity takes longer for those keratinocytes to be able to resurface the wound. The skin becomes more dry because the lipids decrease, but also because hyaluronic acid diminishes and the CD44 expression is reduced. Another concept to be aware of is this concept of dermatoporosis. It's a chronic state of cutaneous insufficiency, fragility. And this can be intensified by UV exposure, smoking, anticoagulants, corticosteroids, and chronic renal failure. So with the presence of dermatoporosis, we see reduced protective function and reduced tolerance to friction and shear. And what's so striking about this is that it's prevalent in 1 out of every 3 to 4 elderly being over 70. So again, it's important to be aware of, because then we can help protect the person from harm. I also want to point out changes in skin function that occur with increased adiposity. So there will be altered epidermal barrier function with this patient population. They have increased water loss, they have dry skin, they have increased sebaceous gland activity as a result of their elevated hormone levels, and they have altered skin pH. So again, risk for bacteria or invasion on the skin, and they have limited capillaries in the adipose tissue. So we know that healthcare is full of old beliefs, old habits, tools, resources. We've used hot water, we've used washcloths, we've used soaps to clean the skin, harmful soaps to use the skin. We've had bad habits. We've seen technology changes, just even how we administer IV therapy. We don't isolate the arm like this anymore. We don't regulate IV flows by hand anymore. So all this to say, we don't do those anymore. And what we have now is a time for change. We need to look at our approach to care, change our paradigm, so that we not only help maintain skin integrity, but we identify at-risk skin, and we help maintain the function of the skin. I thank you for your time, and I have my slides here. I'm sorry, my references here. And at this time, I'd love to turn it over to Dr. Diane Krasner. Thank you.
Thank you, Ruth, for that excellent overview of the literature related to at-risk skin and skin tears. I'm Diane Krasner from York, Pennsylvania, and I want to begin by thanking ISTAP for the opportunity for me to present today on behalf of the Coalition for At-Risk Skin, or CARS. I'll be reviewing for you, in the time we have available, the CARS consensus document entitled At-Risk Skin, Are We Doing What We Think We Are? 21 New Consensus Statements. I will, later on in the presentation, I will give you a link for downloading and reading that document. You can also go to my website, which is listed here, and download the link, or you can email me. My email's here, and I can send you a PDF of the document if you'd like. So I have a disclosure for starters. I serve on the Medline Post-Acute Care Advisory Board and the MUNLICA Speakers Bureau. And I have the following disclaimer to share with you. The focus of the Coalition for At-Risk Skin CARS in this presentation and the recommendations given are limited to topical skin health, prevention, and management. We recognize that holistic patient care is required in all circumstances to optimize skin health. Members of the CARS panel were not paid by Medline Industries for the writing of this document. So to begin, in 2021, at a post-acute care advisory board meeting for Medline, we were presented some data that Medline had collected from their customers related to moisturizers and skin barriers. They looked at patient days, they pulled sales records, and they were able to calculate the amount of product used per patient per day. Now you might ask yourself, what is a significant amount of product? in order to achieve statistical significance. How many patient days should they have looked at and how much product, et cetera? 5,000 patients, 10,000 patients? Well, they actually collected data from 23,590,802 patient days. And what they found, I'm going to show you in the two graphs that are summarized here, that the product utilization results for moisturizer showed that the average amount of ounces per individual per day was 0.09 compared to a benchmark of 2 ounces per day. And for barriers, it was 0.11 ounces per incontinent individual per day compared to a benchmark of 0.68. So significant underutilization of product. And that concerned many of the members of the Post-Acute Care Advisory Board. And so 9 of us volunteered to look at this issue more carefully and see if we could figure out some problems and solutions. And the result of that was this consensus document that we published in November of 2022 as a supplement to Wound Management and Prevention and Wounds. The URL is here, and you can download and read the document from this link. So I'm going to use the limited time we have available to give you an overview of this document and highlight some of the important aspects. So the first thing we did was identify what we mean by at-risk skin. And it was harder to define than you would think. And this was our definition. At-risk skin is defined as the potential for impaired barrier function of the skin due to associated intrinsic or extrinsic risk factors, conditions, and comorbidities. We identified a number of risk factors associated with at-risk skin. You can see them here. Many of them are common, especially in elderly patients. Surprisingly, we did not find a tool for at-risk skin. There are tools for pressure injury, there are tools for cancer screening, but there's no tool developed for at-risk skin. So if that's something that interests you, there's great need for that research. So here are just some of the consensus statements, and I'll just highlight a couple of the important ones. Persons identified with at-risk skin should have initial, comprehensive, and ongoing assessments to develop care strategies that include prevention and risk mitigation. Skincare strategies should be personalized based on product properties and ingredients. So what we're aiming for is for people to have skin that looks like grapes and not like raisins. So I think this image summarizes it all very, very well. So it turns out that the properties, ingredients, utilization, and intended use of skincare products really impact their efficacy. And this includes moisturizers and skin barriers. These products, as a rule, fall under the US Federal Food and Cosmetic Act of 1938, and product claims need to be carefully evaluated before you select them for therapeutic claims. So we'll talk about the ingredients that you should look at, but for details, refer to the document and the many charts and graphs that are available in our consensus document to help you evaluate what ingredients are critical. Number 9 is important. For individuals with at-risk skin, creams or ointments are preferred to improve skin barrier function by decreasing transepidermal water loss. We do not recommend lotions because they can be drying and therefore might not achieve the desired effect. And look carefully when you go back to your facility or home. You may be using a lotion when you really think you are using a therapeutic cream or ointment. So this is just one example from real life of ingredients and how they may be mislabeled or misinterpreted. So these three products all claim to be anti-wrinkle products or anti-aging products. And what is it in their ingredients that allows them to make that claim? Well, it's just sunscreen. Sunscreen is the ingredient that allows cosmetics to claim that they're anti-wrinkle or anti-aging. So we need to be very careful and look at the ingredients list and make sure that the products we're using are really therapeutic and not just cosmetic. So for number 10, for individuals with at-risk skin, a moisturizer should be applied daily at a minimum and always after bathing. The CARS panel recommends for people with at-risk skin, twice daily moisturization has been demonstrated to show additional benefits. Number 11, CARS panel also recommends the appropriate amount needed for a single application of moisturizer to the entire standardized sized adult body is 30 grams or 1 ounce. So we're talking about using 2 ounces of quality moisturizer per day for the average individual, and bariatric patients will clearly need more, but that data about how much more is not available in the literature. So I want to read you number 14. Moisturizers and skin barrier products may have a positive impact on reducing medical device-related pressure injury and medical adhesive-related skin injury, but more study on that and its relationship to skin tears is needed. So we determined that one of the reasons there may be such utilization is because bedside caregivers don't really know what 1 ounce is. And so in this tool or enabler, which we are going to make available as soon as we get our website up for CARS, we've shown 4 real-life examples of what 1 ounce is: an entire medicine cup, 4 packets of ketchup, 3 coffee creamers, a travel toothpaste. So this can help people visualize how much product you really need to be using. We also pulled out in our document 2 large groups of individuals who are at particular risk and need to utilize these guidelines. People who use personalized protective equipment and people at end of life. These really are patient-resident safety issues. And we'll be working this year on additional tools or enablers that focus on high-risk populations for at-risk skin and hope to make those available to you later this year. We also developed a number of statements related to organizations, because in order to make the changes that you need to optimize skin health for your patients or residents, there has to be an organizational buy-in. So these 4 consensus statements speak to the organizational perspective and creating performance improvement strategies so that you can measure whether you're achieving good outcomes in the at-risk skin population. At-risk skin patients, residents should be reflected in your guidelines. So when you go back to your organization, you can ask yourself these questions and reflect about whether you're addressing the needs of your at-risk skin patients or residents? How do you optimize skin health? How will you identify who is included in your guidelines? What data is available to support your outcomes? Do you have what you need to develop an effective performance improvement plan? And how will you operationalize skin health measurements? Our final consensus document, and perhaps our most important one, is number 21. Everyone should be empowered to perform or receive care to promote optimal skin health. So I'd like to summarize with these 4 statements. Persons with at-risk skin will have improved outcomes and enhanced quality of life when individualized skincare strategies with moisturizers and/or skin barriers are used in appropriate quantities. 1 ounce twice a day is our recommendation. And we recommend creams versus lotions or ointments. Creams are the most preferable vehicle. Special attention to populations vulnerable for at-risk skin, that is population health, is a patient resident safety issue. And in our first consensus document, we discussed issues related to PPE and end of life. Our second consensus statement, which we have begun working on, will address the issues related to moisture barriers. And finally, everyone should be empowered to perform or receive care to promote optimal skin health. So I thank you for your attention. Feel free to contact me if I can be of further assistance, or if you'd like access to the CARS document. Thank you again.
Well, thank you very much, Diane and Ruth. Hopefully you can stay online, Diane, for some questions later in the panel discussion. I think what struck everybody is your notion of the visual on the 1 ounce of cream, or the 30 grams of cream, has really sort of hit home with a lot of people, I think. So we have a slight change in the webinar schedule. I'd like to thank my colleague, Dr. Kim LeBlanc, for stepping in at the last minute to present on evidence behind skin tear dressing selection. I would also like to thank Dr. Kevin Wu for his contribution, but there were technical issues with the recording, so we weren't able to show that. But we will make Dr. Kevin Wu's recording available on our website after this webinar. But in the meantime, over to Kim, actually live. So thank you, Kim.
Thanks, Sam. Good morning, everyone, or almost afternoon, or afternoon, evening for some of you. As Sam said, I am not Dr. Kevin Wu, but hopefully I will do this presentation justice. So if I can get my slides to work here. So what I want to do this morning is to talk a bit about a randomized control trial that Dr. Wu and myself conducted just before the pandemic. And it's to really get us to start thinking about evidence to support what we're doing in clinical practice. So just to remind everybody, we've been talking all morning about skin tears, but the skin tears are traumatic wounds caused by mechanical forces, including removal of adhesives. And I think it's important to remember that these are acute wounds. They're traumatic acute wounds, and they should heal in a timely fashion, meaning we should see these wounds healing in 14 to 21 days. We should have complete wound healing. The reality in my practice, and I'm sure many of you, is that skin tears often become chronic and complex wounds. So we're not seeing that acute wound trajectory. So why do we need to study them? Just that, to figure out why they're becoming complex wounds when they shouldn't be, and to look at the pain and suffering that goes along with them, and to see how we can prevent them as well, because they're so prevalent. As you've heard from everybody this morning, these are such prevalent wounds. So when we're looking at dressing selection, some of the factors that will help us decide is the amount of exudate, the location of the wound, the cost of the dressings, pain, peri-wound skin condition, and types of wound. And any of you who are involved in wound care know that cost is something that is a hot topic, because it's not just the cost of the dressing, but there's the time involved in changing the dressing. There's the frequency of the dressing change. So how much of the product do you need? The pain for the patient. So it's multifactorial. So the effects of poor dressing performance, we see leaking and falling off, patient anxiety, frequent pain medication required. We've got reduced patient activity. We get wet wounds. We get that peri-wound maceration. There's problems with bleeding during dressing changes, peri-skin stripping or further skin tears, blistering if dressings are applied improperly. So there's multifactorial things that we have to look at when we're looking at poor dressing performance as well. So we need to pick our dressings carefully. I always say we need to pick our dressings with purpose, so that we're knowing that which dressing we're going to apply, is it the right dressing for the right patient at the right time? And there is no one right answer in wound care. There's always more than one answer for what dressings we should choose, but we need to make sure we have evidence to support what dressings we're choosing. The other thing that has been known is that wounds don't like to be disturbed. Right? Wounds like nice, cozy, warm environments. They don't like frequent dressing changes. So we need to look at the wound environment, we need to look at the wound, and we need to determine how frequently should we be changing the dressings. So there's all-described wound healing. There are lots of different studies out there that talk about this. And we know that at least we disturb dressings, then temperatures remain stable, moist, not wet conditions are maintained. If we have the right dressing for the right person at the right time, we decrease trauma to that wound bed. The least we're disturbing the wound bed, the less trauma we have. And also, if the wound is covered with a proper dressing, and it's left in place, the more it's left in place, if we go back to what Keryln and I were talking about earlier, there's less risk of infection, which is also really important. And there's also that whole stress and anxiety. Many patients talk about stress and anxiety related to wound healing. And our hope is that all these things combined, by less frequent dressing changes, we're going to see faster wound healing. And we're also going to have cost containment. So Kevin and I undertook a randomized control trial to look at the use of soft silicone dressings in the treatment of skin tears. And what precipitated this was ISTAP had released a consensus document on the treatment of skin tears. And we realized that most of there wasn't a lot of evidence. Well, first of all, when we were doing the scoping review for that consensus statement, there really wasn't a lot of evidence. So everything was based on expert opinion. And so this is when we started talking about, well, let's go out and get some evidence. Let's look and see what kind of evidence we can find. So we developed a pragmatic 4-week randomized control trial. We focused on 2 what we call long-term care facilities, or some people call them seniors homes or long-term nursing homes or aged care facilities. So we looked at 2 in the province of Ontario. So that's where both Dr. Wu and I live in Canada. And within the facilities, we randomized the units or the floors where the patients lived into either control or treatment groups. Patients were assigned as baseline weekly for 4 weeks. The endpoint was 4 weeks or wound healing, and we did have ethics from Queen's University. And you can find the publication of this in the International Wound Journal. So our research questions were, is there a difference in the proportion of completed healing between soft silicone dressings and non-silicone dressings? Is there a difference in healing rates between the 2 groups? And primary endpoint will include the proportion of healed skin tears in 4 weeks, so the duration of the study. And secondary endpoints, we're looking at changes in wound sizes as well. So as I said, this was a prospective pragmatic randomized control trial where they were randomized using a computer-based randomized program that was blinded to the researchers. Randomization were conducted on the unit level within the participating long-term care facilities. So the reason we did it on the unit level rather than by individual participant was for ease for the nurses. So we realized that nurses in in these long-term care homes were really stretched. And for us to further add time to their day by having to figure out which patient was on which product, we decided it was better to educate the nurses on the products on each unit, and that for them to understand which type of skin tear they would use which type of either non-silicone or silicone dressing on. So when we looked at it, our inclusion was, we looked at adults over 18 years of age. We had a pretty even split between men and males and females, and the long-term care facility and complex continuum care hospitals. So our treatment group included 65 individuals. Soft silicone all-in-one foam dressings for exudative type 2 and type 3 skin tears were used, and soft silicone wound contact layers for type 1 and 2 skin tears were used for those with minimal exudate. Control group, we had 61 individuals, non-silicone foam dressings for exudative type 2 and 3 skin tears, and non-adherent non-silicone dressings for type 1 and 2 skin tears with minimal exudate. And these were standardized treatments. So the control group products were standardized treatments that are used for skin tears treatment in those facilities. So our inclusion criteria was over 18 years of age, residents participating, living in long-term care facilities. They had to have a skin tear. We included all types of skin tears and all levels of exudate. Our exclusion criteria was factors that may compromise wound healing. So such as individuals who had a previous skin tear at the time of the study, severe medical conditions, non-compliance, or infection. So our key measures were that all subjects were evaluated at week 1, so entry into the study, week 1, week 3, so at the end of the study. Weekly measurements of wound sizes and wound surface areas, proportion of changes in mean surface area over a 3-week period. So we looked at survival data, and we did wound photography as well. And skin tears were classified using the ISTAP, or International Skin Tear Advisory Panel's skin tear classification system. So how did we define healing? Healing, completely healed type 1 skin tears was when we had a dry, slightly firm healing ridge or new epithelium had formed along the edge when the flap meets the skin. And completely healed type 2 or 3 skin tears were when the wound edges and were bridged by new epithelium, including an establishment of a healing ridge. The development of a healing ridge we described as an area of swelling and hardness under the reapproximated skin edges indicated the deposition of new collagen in the wound. So this is just how we determined what definitions we use to establish wound healing. So when we looked at types of skin tears, we had 12 points, so almost 13% were type 1. And then we had an even split of just about 44% of type 2s and type 3s. And this is supported in the literature when you look at the types of skin tears that are normally reported during prevalence studies. It's pretty well this split as well, where we see the majority are type 2 and 3. We looked at skin tear locations. This was no surprise either, with a pretty even split between legs and arms. As you heard Dr. Carville speak earlier this morning, that predominantly these wounds do occur on the arms and legs, but it's important to know they can occur anywhere on the body. So we did have them occur on the hands, the back, the feet, the head and face, buttocks. So we did have them occur elsewhere on the body. Now, we also thought we would need to track some of the reported extrinsic factors by the staff just to see how this correlated with the literature. And it very much did in terms of we found the majority of the reported extrinsic causes were blunt force trauma, self-harm or scratching, an unknown cause. Now, some people may be surprised that adhesive injuries as low as it is, but remember that these wounds occurred in an aged care home where we don't use a lot of adhesives on people's skin. If we were to conduct this study in acute care, we would most likely see adhesive injury much higher on this list. But in the aging population, the top 3 that were reported, and certainly in all the studies that I've done during my doctoral work and since then, we see the blunt force trauma, self-harm, scratching, and unknown, meaning that someone will just suddenly see that they've occurred, are really the top causes that we see. So we looked at our treatment groups. We had a good even spread between the different groups as well when we're seeing the use of the different dressings. So we saw that silicone foam and non-silicone foam dressings were 43% and 35% respectively. Slightly higher use of silicone contact layer compared to non-adherent contact layer. So here's when we get into the actual looking at the results. So we looked at wound surface area reduction first. And what we found was that initially, when we looked at it, we are very surprised by the decrease in surface area at week 1 between the silicone group and the control group. So there was a significantly greater reduction in wound surface area relative baseline in the treatment group compared to the control group. So we thought this was quite interesting. But then we looked at time to heal, and this was another interesting phenomenon in terms of when we looked at the proportion of wounds that were healed at week 1, 2, and 3 among the groups. We can see that there's a huge difference between the number of silicone and the silicone group and the control group in terms of wound healing. And we looked at the percentage of wounds. We saw that the silicone group at week 1, we had almost 50% of our wounds were considered healed at that time, compared to 10% of the control group. And then when we got to week 2, we had almost 90% of the control group versus only 28% of the control group. And then by week 3, we had just about 97% of our silicone group, meaning almost all of our silicone group had moved to healing versus only 34% of our control group. So this is a huge, can potentially have huge impact when we're thinking about wound healing, cost of dressings, pain and suffering for our patients. So then we did look at healing time, and we looked at time to heal in days. So the average time in our control group was 20 days versus our silicone group was 8.6 days. So we can clearly see here that, and this is obviously significant results, that wounds in the silicone group did heal more than 50% faster. So what were some of the conclusions that we had? Well, the soft silicone contact layer showed clinical benefits in the treatment of skin tears type 1 and 2, and the silicone foam dressings in treatment of skin tears type 2 and 3. There was a significantly greater reduction in wound surface area related to baseline in our treatment group compared to our control group. 88% of patients achieved complete wound closure at week 2 in the treatment group compared to 28% in the control group. Skin tears in elderly patients with a mean age of 82.9 years healed over 50% faster with soft silicone dressings compared with conventional non-adherent dressings, approximately 8 days versus, so that's 8 days versus 20 days. Now, this is one study, so obviously we do need to move forward and to conduct further research. This is just one study. We need to look at skin tears and the management of skin tears across the spectrum of products available. So my challenge goes out to all of you to think about doing research in this area so that we can gain more evidence as to what is the best method for treating skin tears. I think at this point, I know we're going to do questions in a little bit longer, so I'm going to hand this back over to Samantha.
Thanks, Kim. Well, actually, we're doing okay for time. So if we're going to keep to the program, Jackie's session doesn't start for a little while. So perhaps if it's okay, Kim, if I can bring you back in for some questions, if that's all right.
Certainly.
Thank you. As if by magic, there you are. So there was one question which you did cover quite quickly, but maybe we could come back to it because I'm sure it's something a lot of people will be wondering about, is the idea of dressing changes and how often to change a dressing, specifically for skin tears, because we know they need to be understood. But could you just talk about that a little bit more to give some guidance for our participants?
Yes, certainly. So one thing we aim at is for weekly changes. Most dressings are formulated to stay in place, and the companies, say they could stay in place for up to a week. There are some some exceptions to that can stay on longer, but we aim to change dressings for skin tears once a week. But I think it's really important to remember you have to look at the wound and know how much absorbency does that wound need? What kind of frequency does that wound need dressing changes? Is it infected or is it not? Whatever comorbidities are there. So for instance, if I have someone who has a skin tear in a lower leg, one of the first things that I do, Sam, is I do a head to toe assessment, including a complex lower leg assessment to see, is this person appropriate to put into compression? Because we know that anybody who has a wound, there is going to be localized edema. And so one of the things I'm really interested in studying is the concept of putting compression therapy on lower limbs for people who have those pretibial skin tears on lower limbs. So, you know, that's something else that we'll do. Well, with that, we change the dressings once a week if we can get them into compression. And what we're finding is if we can control the edema, control infection, minimize dressing changes, we can get these wounds healed in 2 to 3 weeks versus having them become chronic and complex wounds. So there is no easy answer in terms of the frequency of dressing changes, but we aim for the utopia, which for me is once a week, and then we adjust according to the patient's assessment. And I see Sam Usi or Karen Usi just popped in the chat that toe-to-toe assessment is essential. I think she means head-to-toe assessment. I'm hoping she means head, or maybe she means down one toe, up the other, and down the other. But
it would be, wouldn't it?
Certainly, you know, that complex assessment is so important. And so often people do say, well, it's just a skin tear, so we're just going to slap a dressing on it, and we're not going to do that complete assessment. And we have to remember that when we don't do that, that's when they become chronic and complex wounds.
Thanks, Kim. And a follow-up question actually has just come in. So there's Neela, maybe Silkins, has asked, so at their hospital, they leave the silicone dressing on the wound for 7 days, but they daily change the compress on the silicone, so the kind of the secondary dressing, I guess, and they clean the silicone dressing. Does this disturb the wound?
Well, you are decreasing the temperature. Right? That's one of the things. Every time you lift up the dressing, you are decreasing the temperature of the wound. And I can't remember off the top of my head the optimal temperature for wound healing. I just know that there's studies that have shown that, you know, wounds like to be at this optimal temperature, and every time you change the dressing, you will lower. So what I do in our aged care homes is, yeah, we'll put on the soft silicone and we'll cover with a secondary dressing. Quite often it is one of these absorbent pads, like abdominal pad type dressing, and we'll have them change it every 3 or 4 days, depending on the amount of exudate, because these pads don't absorb as much as a foam. So if there's minimal exudate, you can leave them in place for up to a week with that soft silicone on top, especially if for those type 1s and 2s where you can pretty well approximate the wound edges.
Thanks, Kim. There's lots of comments coming in about dressings, so perhaps we can deal with those now as we do have the time.
Sure.
So questions come in from Kathy Dimmock. Thank you, Kathy. For dressing treatment, to be clear, we could use a silicone wound contact layer and then apply an alginate AG on top for bleeding or drainage, covered with a boarded silicone foam dressing.
So I think that's really, I mean, it's overkill, I think. The silicone foam dressings are designed to be in direct contact with the wound. If there's bleeding, what I normally will do is, if there's a significant amount of bleeding, and a lot of these aging individuals are on multiple medications, including anticoagulants, so we will have bleeding. So what I'll have the nurses do is put an alginate on, not a silver alginate, because this is a traumatic wound. If you clean it properly right away, you shouldn't have infection. So we'll use a plain alginate, leave it on for 24 hours. Then I'll have the nurses gently remove it, and then we'll move into a silicone foam dressing or a contact layer, depending on what the wound needs. So I don't normally use silver dressings. I don't use any antimicrobial dressings unless I'm seeing clinical signs and symptoms of infection. And frequently what people will get mixed up with is that whenever we get a traumatic wound, during that initial 24-hour period, we have a reactive inflammation that happens. It's part of the inflammation process of the wound healing. So you'll get this reactive erythema, and people are really quick to say, oh, this is infection, when the reality is it's just normal wound healing. So we need to make sure we're differentiating between inflammation and infection, particularly in traumatic wounds.
Thanks, Kim. I'm just going to keep you there for a bit longer, grilling you. It's not a question that's come in now, but it did come in earlier about how we cleansing options for skin tears. So it might be useful to just talk about that for a minute or so, about what you choose to clean skin tears with.
So number one, we need to remember that these are traumatic wounds, and we often don't know the mechanism of injury. So it's really important that, from my perspective, that we set things up for wound healing right from the beginning. So the nurses I work with, we use, we will use what word am I looking for? We'll use the antiseptic wound cleansers to start. So something like hypochlorous acid or something like that to clean the wound really well. The same, and we think about, especially if we're going to reapproximate the skin edges, you have to think about that the same as if you were suturing a wound. You're closing a wound by primary intention. If it's a type 1 skin tear and you're reapproximating that flap, or even if it's a type 2 and you're putting the flap back on. So if you were to have a laceration and you went to the emergency department and a physician or nurse practitioner was going to suture your wound, they wouldn't just flush it with normal saline and suture it. They would use an antiseptic before they're suturing it. And the whole concept is around preventing infection. So that's how afterwards, we can switch to normal saline, but initially I do ask them to use an antiseptic to cleanse the wound, reapproximate using sterile technique, reapproximate those wound edges, and then select your wound dressing appropriately. But you also want to remember, you don't want to cause further damage. So you want to gently flush the wounds. You don't want to be using high degree of pressure to flush these wounds. You don't want to traumatize the skin any further. So really gentle wound cleansing. But I do a good thorough cleansing. So it's not just a sprinkle either. It's a good thorough wash, and then we will reapproximate the edges.
Thanks, Kim. There's still lots of questions coming in, but we'll hopefully have time to come back to those. One of the things I just do want to address is, in one of the pictures in your presentation, you did show a skin tear with a wound closure strip across it on the top. So could I just, I know, and in the chat, Harry and I have been discussing with others about wound closure strips. So I think it's probably appropriate just to talk about that for a minute.
Yeah, so wound closure strips, I mean, for a long time, those were standards of practice. For skin tears, that's what nurses globally would use. And it's become now one of those sacred cows. Well, we always use them. But the reality is, most of the time when people put the skin closure strips on, they don't reapproximate the edges well enough. So then there's actually exposed wound bed left open to the air that becomes dry and desiccated. And also an entryway for infection to enter. So we end up having wound that's not completely closed, an entryway for bacteria, so we see more infection with these as well. And what we're seeing on removal is frequently the flaps are ripped off and new skin tears are occurred when they do the removal of the steri strip or the skin closure strips as well. So I guess, one of the things, if that's the only thing you have available to you, then it's better, I guess, than nothing. However, we've eliminated them almost completely in all of our long-term care homes. I can't remember the last time that I saw someone using them. And what we're seeing is the healing rates for our skin tears are doing much better. We have fewer infections, fewer complex wounds developing. So this is an area that does need further study. This is all based on expert opinion. And I think we do need to do some randomized control trials looking at skin closure strips versus using a non-contact layer or some of the other dressings that are available, such as the cyanacrylates.
And I guess one thing to say, Kim, would be that if anyone finds a skin tear has been closed with wound closure strips, it's probably best to just leave them on there and let them fall off naturally than try and remove them, because it's the removal of them that often causes the problem. So
unless you suspect your wound's infected.
Mm.
So if the wound's infected and the skin closure strips are on, then you need to very, very gently remove them. There are, if you go to the ostomy world, we do have wonderful adhesive removers that we use for our ostomy appliances. So you can use adhesive remover to gently remove those skin closure strips and then deal with your infected wound as well.
Thank you, Kim. I feel like I've grilled you enough now. We'll come back to you at the end in the question and answer session, but thank you very much, Kim, particularly as you stepped in at the last minute. So thank you as always. Thank you.
Thanks, Sam.
So we'll move on to our next presentation, which is a colleague of mine, Jackie Fletcher. Jackie's going to talk about the application of the Askin bundle to skin tears. So thank you, Jackie.
About the application of the Askin bundle to skin tears. The information I'm going to give you today are my own personal views and not those of my organisation. I'd like to start by posing a couple of questions. Do you think we're asking too much of our clinicians? Could we all be using the same language? And I think those are quite challenging questions because we're all working in a really busy environment and we have things that we need to achieve and they have things that they need to achieve. But are we actually making their life difficult with what we're asking of them? And I ask the question because we're all facing similar challenges. Wherever in the world we're practicing, our staff are under huge workload pressures. We know we are short of clinical staff and that they have so many things to do within their day. Managing to deliver education or managing to get people to come to that education can be very difficult because they don't have the time or capacity in the day to do so. And we complicate matters by giving them a completely different framework for everything. Is that just too confusing for them that they have to think about how they assess the skin in a patient with a leg ulcer in one particular way or how they assess the skin in a patient with a pressure ulcer in a completely different way? Could we use similar or the same things to help make their life simple so that when they're faced with a patient with a skin challenge, they know exactly what they have to do and don't have to start thinking about what the etiology is, just that they have a patient with a skin challenge. In case you're not familiar with Askin, I'll start off by giving you a little bit of an explanation about where this bundle came from. So the Askin bundle is something that's quite peculiar to the UK, but it's a development from what was originally the skin and then the Suskin bundle. And in England, we developed this green hand symbol, which easily represents the Suskin bundle because it has the 5 elements. And what it asks us to do is to focus on these really key points of care. And in Suskin, we start off with the surface that the patient is in contact with. We consider the patient's skin, and that's skin assessment and skin care. We focus on keeping the patient moving. We consider their level of incontinence, and we look at their nutrition and hydration. The important part of it, though, is that this is a bundle, and the bundle concept in healthcare have been around for quite a long time. They came from industry, and they are a way of assuring quality improvement. What bundles do is deliver a small number of interventions consistently and reliably. So in a bundle, it's not good enough that you deliver 4 out of 5 things 100% of the time. You have to deliver every single one, every single time, on every single contact. And what that does is maximise the prevention opportunities. So there's really strong evidence, both in wound care and in infection prevention and control and line management, that the implementation of a bundle not only helps staff to remember what to do, it improves patient outcomes. And it helps them to remember what to do because generally they're easy to remember and they're very familiar to them. So Askin is a move on from the Suskin bundle. And we developed Askin because we felt there were a couple of elements that were really missing from the care that was being delivered. Not that the care was lax, but that the bundle didn't incorporate these elements of care so that it was easy for staff to forget them. And the more we looked at it, the more we felt that the assessment of risk was really important and that the giving of information was important. In terms of the bundle though, and the reason that the A and the G are presented as lowercase letters, we see these as underpinning principles because assessing somebody's risk doesn't prevent a harm happening to them, but assessing their risks helps us to target the resources and the actions we're going to do to help prevent the harm. And the same could be said for giving information. Importantly, in giving information, it's not just about giving information to the patient and their family and carers, it's also about giving information to your clinical colleagues. So ensuring that all of the team are on the same page, we all know what the objectives are, we all know what the challenges are, and we all know the direction of travel. Using asking also lends itself to some nice sentences. So you can see here is what we call a lozenge. This is something we use in our Stop the Pressure days. It's a way of raising awareness, raising the profile, and it's really easy to build asking into a sentence. So you can see here we've got, are you asking the right questions about great skin and pressure ulcer prevention? And so you could use this very simply to just say, are you asking the right questions about great skin and prevention of wounds or prevention of skin harm? It's important, I think, to consider how this might apply to skin tears. So when I wanted to look at this, I went to the best practice recommendations for the prevention and management of skin tears, which is on the ISTAP webpage. I'm sure you're all very familiar with this. The document was produced in 2018. There's been several other excellent documents since then, but this felt a really good place to start. And I'm quite a visual person. I like to be able to see things and how they fit together. So you can see what I've done here is put you together a table that talks about asking in terms of pressure ulcers. And this is how we present asking for pressure ulcers. We talk about using risk assessment tools, and in England we're recommending the use of Purpose T. And we talk about both the assessment of the skin and the management of skin. So skin assessment, visual assessment, tactile assessment, making sure you're touching the skin, checking the temperature and the texture is really important, as well as what you visualize. But once you see something, you need to deliver some care, and making sure that the skin is clean, dry and well hydrated, and if necessary protected, are really the fundamentals of the care that we deliver. For pressure ulcers, the surfaces are always seen as really important, and when you talk to any clinician about pressure ulcer prevention, one of the things they will automatically leap to is to talk to you about beds and mattresses and the specialist cushions that we use. Also specific things like heel prevention devices, but we also need to think about things like manual handling. The surfaces that we put between the patient and their protective surface are really important. The way we use things like hoists and slings really contribute to pressure, friction and shear, and they can make a significant difference. It's important to keep the patient moving. The biggest risk factor in pressure ulcers is immobility. So we need to regularly reposition the patient, but we also need to encourage independent mobility. And this is a really crucial aspect of care for patients, particularly older patients. We know that the longer they are immobile, the more they become deconditioned. There's really strong evidence that shows that admitting a patient to hospital results in significant reduction in their muscle mass and puts them at far more risk of lots of other complications. So keeping the patient independent and keeping them moving is really crucial. And that's often a real balancing effect, because we're often very worried about them falling. So we're also telling them to make sure you don't fall. We're also telling them to make sure they don't bang their legs so that they don't get skin tears. But we need to make sure that we don't knock their confidence. So we need to give them the confidence to mobilize safely within their environment and promote that mobility, because it keeps their independence and it keeps their muscle tone, and it also gives them confidence to do other things. For pressure ulcers, we focus on managing increased moisture, a key element of which is obviously incontinence. But we also need to think about things like sweat and wound exudate that may contribute to an increased friction coefficient on the skin. And moist skin is always at risk of harm, far more risk of harm than dry skin. Nutrition and hydration are important in all elements of prevention, and for good skin care we need to ensure that the patient is receiving adequate protein and other dietary requirements, but also that they maintain their hydration status. And this can be difficult in older patients where they're very worried about the need to go to the toilet, so they may limit the amount of fluid they use so that they're not incontinent. They may be worried about falling if they go to the toilet, so again they try to reduce their visits to the toilet. So we have to make sure we give a very positive message about maintaining that hydration, the benefits for them overall, but also the benefits for their skin. So when we're talking about well hydrated skin, we can be talking about the patient drinking, or we could be talking about application of creams and moisturizers and emollients to the skin to increase that skin resilience. And as I said, giving information is really important across the board. So we talk about communication with the team, we talk about communication with the patient and their family. And I think it's really important that we are clinically curious, that we challenge people, that we think about what's happening to their patient and their family, what happens in their own environment. We get a lot of people talking to us about patients being non-concordant with care. I don't believe that patients are deliberately difficult. I think if they're non-concordant for a reason, and that sometimes we fail to get to the bottom of that. And unless we get to the bottom of it, then we will never understand what the problem is and be able to resolve it. Giving information also means make sure that we're documenting clearly in the clinical record what we have done and why we have done it, and also what we haven't done. And it also helps us to get patient engagement, and patient-centred care is really important, and that supported self-care really makes a difference to their outcomes. So I think it's really clear in pressure ulcer prevention we're asking SITs, but does it sit the same way if we're thinking about skin tears? Well, yes, I think it does. So you can see here I've talked about the assessment of risk. We think about falls risk. We are thinking about their skin condition. Have they already got factors that make them at risk, like elderly, thin, frail skin? Has the person got dementia? Does that increase their risk of banging into things? Does it increase their risk of challenges with their skin? And as their mobility decreases, are they more likely to have sustained falls or hang on to furniture and be close to things that they might bang their arms or legs on? Skin care is exactly the same. The surfaces, we might think about something different in terms of skin tears, and it's very much around things like protecting from sharp surfaces. So thinking about the shape of tables, or can we pad them so they don't bang their legs, and that protective clothing. But again, the same manual handling considerations. When we're talking about protection from skin tears, those shear forces that remove those surface layers of the skin are really important. And the same for maintaining mobility. We need to get that mobility in a safe environment to prevent the falls, to prevent the skin damage, to prevent the deconditioning. Increased moisture in skin tear prevention, we might be thinking about the risk of incontinence here, and particularly if somebody waits to the last minute to go to the toilet because they feel less likely to mobilise or they're worried about mobilising, that sense of urgency might mean they're less careful and more likely to bang themselves as they're going around. Nutrition and hydration and communication, that giving of information, I would say are exactly the same. I looked into the best practice document to see if I could reinforce my ideas, and it was very clear to me that the asking framework is very much followed in there. So you can see from that best practice recommendations document, there is a whole section that talks about skin tear risk assessment. And it's really important to identify patients that are at risk or not at risk, because for the patients that are at risk, we can start to think about implementing a risk reduction programme. And the same is true for skin assessment and care. You can see clearly highlighted within the document a list of things you might need to think about in terms of the skin, both inspecting the skin, thinking about previous history of skin tears, checking the overall condition of the skin and how that might relate to risk of trauma, managing the dry skin, so that use of emollients to keep the skin well hydrated, thinking about avoiding use of soap, thinking about how you might protect the skin if you're using any dressings or anything that's adhesive, thinking about the medication you might be using and how that impacts on the skin, and thinking about protective clothing, but also thinking about the surfaces that you might have in contact with the patient, such as sharp fingernails or jewellery that you might be wearing that might cause skin damage and particularly cause skin tears. My own mother developed a skin tear from putting her tights on, where she caught her own leg with her nails and had quite a difficult to manage skin tear. When we're thinking about how skin tears happen, most of them happen because of contact with some form of surface. So they happen because of blunt trauma, they happen because of falls, they happen during those activities of daily living. But a lot of them also happen during patient transfers when we're using equipment to do that, or because of equipment that we put patients in. So if you think about things like wheelchair foot plates, they're very easy to bang the ankle or the lower leg on. Think about the armrests on chairs. And also, as I previously mentioned, this thing about your own fingernails or the patient's own fingernails or the jewellery that they're wearing, that as they get dressed or as they carry out activities of daily living, what impact that can have on them. We might think about the positive aspect of the surfaces. What can we do to make sure the patient's wearing appropriate clothing? or appropriate things like retention bandages for protection. But do think very much about the furniture and the environment around the patient and how those surfaces interact with them to increase their risk of harm occurring. I've already talked a lot about keeping the person moving, and I think the important thing is about safe mobility, and really think about what you can do to get that person into a robust position or being as independent as they can. And that's remembering things like exercises. If physical function is impaired, what can you do to maintain that muscle strength? Think about how you're transferring the patient in a safe way. And we are very guilty. I know I've certainly done this when we're trying to mobilise a patient. We sit them up in the bed, we swing their legs round, and then we say things like, just shuffle your bottom to the edge to help get your feet on the floor. Actually, that's really not a safe practice to do. If you think about that shuffling action, if there is no slide sheet or glide sheet between the patient and the surface, the risk of shearing forces to their skin is really high. So when we're promoting mobility and independence, we really need to think about the safe practices that we're doing. We need to do those balancing things like making sure that the patient's not at risk of falling, and we do that by making sure that their environment is safe, that they've got good footwear, that they're wearing their glasses or their hearing aids so they can hear us talking to them and ensure what they need. Make sure they've got good lighting, that we remove obstacles where possible. And if they do have objects that have got sharp edges, what can we do in their home environment that doesn't look too horrendous to pad that? Can we reposition it? Can we use something soft around the edge? How can we make that work for the patient? And don't forget pets. Dogs and cats have a habit of jumping up on people. It's often in those situations that the wearing of long sleeves or wearing trousers instead of skirts can protect the skin a little bit more. And incontinence can be a challenge if we're thinking about that increased urgency that we mentioned, or if the patient is actually incontinent and the surface that they're on then becomes wet and slippery. It can cause a fall, or it can cause them to slide and bang themselves. And we know that moist skin is more susceptible to friction damage. For all patients with or at risk of any wound, it's important that we optimise their nutrition and hydration, and if necessary, refer to dietetic colleagues to get that level of support. And where the patient is at risk of a skin tear, it's really crucial that we educate them and their carers about their risks and what they can do to help prevent, and get them actively involved in those care decisions where appropriate. And you can see again, this information comes straight from that best practice document and talks about making sure that we get appropriate specialists involved if there's impaired sensory perception, and that if needs be, we escalate when we feel there's a challenge. As you can see, we're back to this slide. Should we all use the same framework? I don't think anybody will disagree with the fact that we have these pressures, but will using something that is very similar make a difference? Will it really help staff to concentrate on what they should be doing rather than having to learn about completely different things all the time? And I think this to me is really clear. When we start to think about the pathway of cares, we can see how all wounds actually should be following the same pathway. So if you have a patient and you think they're at risk of any wound, we should be following the same steps. We should be doing some kind of screening or risk assessment to identify their risk of wound, whether that's a pressure ulcer or whether that's a skin tear. If we identify that they were at risk, then we deliver the appropriate preventative care, and I'm suggesting we do that around the skin bundle. Hopefully, if we deliver good care and the patient is engaged and nothing goes wrong, the patient won't develop a wound. They might remain at risk, but they don't remain a wound. We continue with prevention. Unfortunately, we know that some people will move to that higher level. They will develop a wound. In that case, as recommended in all the ISTAP documents, you should be delivering evidence-based care. And in a good scenario, that wound will heal without complication, and we just have to be aware of the scar and escalate our preventative actions because they've now got a scar, so we know they are definitely at risk, and make sure that nothing goes untoward and they develop another harm. However, sometimes, despite our evidence-based care, the wounds fail to heal, and the patients we're dealing with are often complex and frail and have multimorbidities, so that does happen. And here again, we should be thinking very quickly about evaluating the care we've delivered, and does that need to be escalated to a more specialist clinician or a more senior clinician, or to a different service to help us improve the care and to move that wound onto the wound healing trajectory. And I think these are really core steps in a pathway for any patient with skin challenges. So whether this is about the patient having a skin tear, a pressure ulcer, a leg ulcer or a diabetic foot ulcer, I think the pathway is exactly the same. Let's focus on prevention as our first line. But once they do develop a wound, let's make sure that we're delivering evidence-based care to ensure that we move them into that healing trajectory as quickly as we can. So I'm putting forward an idea that asking shouldn't just be about pressure ulcers, it should be about good skin care. It should be about maintaining our patient's skin in a healthy condition. Because you can see here from this table, I've now expanded it to not just pressure ulcers and skin tears. You can look at diabetic foot ulcers, you can look at leg ulcers, you can look at patients developing surgical wound complications. And actually you can see in lots of those columns I've just written as above, because the interventions are exactly the same. There may be slightly difference in the risks that we assess, but it's about assessing risks, and those are particular to the patient and their circumstances. They're not the same across everything. There is always a challenge about surfaces. Think about the surfaces around the patient and the impact they have on their skin. And the moisture may be different. So for example, if you're thinking about a patient who has a venous leg ulcer, you might be thinking about that very edematous limb with lots of leakage. But moisture is always a problem. So it's just a thought, and it's just my thought, but wouldn't it make life much easier if we all focused on great skin care and we use that same acronym throughout? If we all talked about, are we asking the right questions to make sure that our patients have good skin, healthy skin, and we prevent harm happening to them? Thank you.
Thank you very much, Jackie, for your presentation. And I can see Jackie has joined us. So we're slightly ahead of time, but that's always good because it means there's more time for questions, and there's actually quite a few questions come in. So I'd like to invite the panelists to put their cameras on, who's taking part in the panel Q&A. And I'm going to hand over to my colleague, Emmy Nokaneng, who's now going to facilitate the Q&A session. Thank you, Emmy.
Thanks, Sam. Let me just put on. I think I'm having a slow connection.
That's okay. We can hear you okay, Emmy.
Okay,
there we are.
we
can see you. Welcome.
Thank you very much. And it was a very informative session, and we've got quite a few questions. Let me start right at the top. There was a question. Let me just look at the questions here. There was a question from Trish Edison, who asked, what do you suggest clinicians can do to promote restoration of the skin microbe within the healing process and post-healing? I think that was right at the beginning of the presentation, so any of the panel members can also answer that.
Was it the skin microbiome, Emmy? Sorry,
Yes,
the sound went a little bit. Okay.
Yes.
So it was just clarifying the question was on the microbiome. So I don't know if anyone has any thoughts on that.
How do you promote this restoration of the skin microbiomes during the healing as well as the post-healing phase?
I think we can go back to the basics. Oh, okay. Go ahead, Karen. Go ahead. I think, and you can build on this, Karen, I think we should go back to the basics of good skin care and wound care. So if we're doing proper hygiene, we're cleaning the wound and the peri-wound skin, and we're doing moisturizing and picking proper dressings with the least level of adhesive, I think we're going to go a long way to promoting healthy skin and healthy wound healing.
I totally agree, but I also think it was what Fiona was talking about as well, and she was saying about good nutrition and doing a full assessment. So a top to toe, as I said earlier, Kim, assessment, but looking at comorbidities as well. She's saying don't forget that these people who have skin tears tend to be older, they're aging, they've got a range of comorbidities. So not just to look at the skin tear itself, but to see what else is going on. So to maintain nutrition, to keep pain free, and that will help with the skin microbiome as well.
Just to add, if I may, I mean, what we call is, if you look at the products that are being used, whether it's moisturizers, emollients, or dressings, or that, the one that has got the least change on the skin itself is important for the microbiome. That means if it's not too acidic or too alkaline, you know, those kinds of things, together with what we call this perfumes and all kinds of additives, and you have got other chemicals. So anything with this basically can cause a lot of problem with the microbiome. I think we have to basically make it simple and something which is, you know, proven to have only a few particular products inside. That means basically like glycerin per se, or even simple silicone dressings per se. So it doesn't actually affect the microbiome around the area.
Interesting you should say that, Harry, because the next question says, what are your thoughts on the pH of soaps that we use?
Yep, that's
So
what I
which
wanted
also
to mention.
which tend to affect the microbiology of the wound.